We ask all of our guests to take their seats. The Subcommittee on Health will now come to order. I'll recognize myself 5 minutes for the purpose of an opening statement. And this morning, we're convening today to learn about opportunities to improve the 340 drug pricing program. This hearing builds on previous work done by the Committee on Energy and Commerce and the Oversight and Investigation Subcommittee in this Congress and last Congress. The Subcommittee on Oversight and Investigations has held hearings on aspects of the program over the past several years. That subcommittee also issued a comprehensive oversight report on the program earlier this year. As we start this morning, it is important to emphasize that members of this committee, both sides of the dais, each understand the importance of the 340B program to safety net health providers and many communities in large and small across our nation. The program enjoys strong bipartisan support, and it helps many healthcare providers give care to vulnerable Americans. At the same time, it is worth noting that Congress established the 340B drug pricing program over 25 years ago through the enactment of the Veterans Health Care Act of 1992. So just for purposes of reference, Cold War still going on, or right at the end of the Cold War, right at the beginning of the internet age. Certainly, we can all agree that our healthcare system has evolved significantly since that time, and it is reasonable to review how the program is working with today's realities. The 340B program is a success. At the same time, there are ways in which the program's current operation raises valid concerns. Multiple reviews by nonpartisan auditors have identified challenges within the program's current operation and oversight. For example, we know that the Health Resources and Service Administration, the agency charged with oversight of the 340B program, lacks some key regulatory authorities. Additionally, the Health Resources and Services Administration has delayed multiple program regulations repeatedly without a compelling and clear rationale. We've learned that in 2016, HRSA audited less than 2% of total entities participating in the program. There has also been uncertainty about where the savings from this program are going and how certain covered entities may be utilizing the revenue generated from the program. The newest concern with the program's oversight has been highlighted by the Government Accountability Office. Today, we will hear from the Government Accountability Office, who recently released a groundbreaking report on contract pharmacies. We all know that the number of contract pharmacies has grown rapidly since HRSA issued guidance in 2010 that allowed covered entities to contract with multiple pharmacies. Since then, the number of pharmacies that covered entities have had contracts with has increased from 1,300 to over 20,000 last year. I think the Government Accountability Office raises a number of serious challenges with HRSA's current oversight of contract pharmacies. I think we all should be concerned by the fact that many of the covered entities that the GAO reviewed do not have in place a policy that ensures uninsured, low-income patients are not hit with a big hospital bill for their outpatient drugs. Certainly concern about healthcare costs, drug costs, hospital costs, other costs is an ongoing concern. I have a discussion draft today which outlines one possible solution to this issue to ensure that covered entities stretch resources through the 340B program while making certain that some of the most vulnerable patients see financial benefit. Overall, I've found this is an eye-opening report, and I hope we will each review it carefully as we seek to ensure it's effectively implemented. I appreciate that members here approach the 340B program with different backgrounds and a variety of perspectives. I trust we all share the same goal of ensuring that this federal program operates with integrity and that the program is appropriately transparent and accountable to patients. Ultimately, today's hearing is an opportunity to engage in a dialogue and exchange ideas about what may be the best way to move forward with improving the accountability and transparency of the 340B program. In addition to what I anticipate will be a lively debate, we will be evaluating more than a dozen legislative proposals that address some of the concerns that members have. These bills, whether drafts to generate discussion or introduced bills are members' ideas from both sides of the dais to improve the 340B program. I support several of the policies outlined in these bills. Others have caused me to have some questions. But we also need to hear from the wide range of stakeholders impacted by this program. We do want to welcome Deborah Draper, the Director of Healthcare at the Government Accountability Office. Thank you for your time this morning and welcome to our hearing. And I want to thank you in advance for your willingness to testify before us and answer our questions. I also want to give a welcome to Dr. Fred Cerise, the CEO of Parkland Hospital in Dallas. I wasn't born at Parkland Hospital, but I spent the better part of my life there. Well, it seemed like a better part of my life for 4 years during my internship and residency. I also want to welcome Dr. Deborah Pratt, Vice President of Texas Oncology. Both of those witnesses will be in our next panel, as well as Dr. Charles Daniels from California. Today's hearing promises to offer a number of thought-provoking ideas to inform our next steps to improve the 340B program. Thanks to each of our witnesses. I now yield to Mr. Green of Texas, the ranking member of the subcommittee. 5 minutes for an opening statement, please.
Thank you, Mr. Chairman, for holding today's hearing, and thank all our witnesses for coming here to testify on this important issue. The 340B drug pricing program was created by Congress in 1992 to help safety net providers care for their most vulnerable patients and afford drugs that would otherwise be out of reach. Since its creation in 1992, stakeholders and policymakers have debated the intended purpose and appropriate scope of the 340B program. And Mr. Chairman, I'm glad we are having this hearing since I've been on the subcommittee. This is our first, I think, oversight hearing on 340B, and I agree with you. It was created in 1992. I didn't get here until 93, so I don't remember us having an oversight hearing on this, but I think we ought to share how important the 340B program is needed to stretch scarce federal resources as far as possible to reach more eligible patients and provide more comprehensive services. The law does not specify how savings incurred from 340B discounts must be used by covered entities, a point that's highlighted both by the supporters and opponents of the program. GAO studies have confirmed that large and covered entities use these savings to provide more care to more patients, including medications that otherwise would be unaffordable to those who serve. For example, the Harris Health System, our public hospital system in the Houston area, primarily serves the indigent population of Harris County, Texas, saves $90 million a year through its participation in the 340B program. Harris Health uses the savings from the program on patient care services, which include the cost of treatment, administration, management of services and facilities, and improves access to quality health care for our community. We also have MD Anderson Cancer Center, Texas Children's Hospital, and Memorial Hospital systems who benefit from that. Harris Health System and the other safety net hospitals across the United States provide access to cost-effective, quality health care delivered to their patients, regardless of their ability to pay. There will always be more patient need than capacity to provide, and the community's access to care depends upon the contribution of every possible source of funding, including 340B. The 340B program has grown significantly in recent years, and oversight is appropriate. Our uninsured has grown over the last number of years, too. According to the GAO, the number of 340B entities have nearly doubled in the past 5 years to over 38,000. Similarly, the number of contract pharmacy agreements have grown dramatically since 2010, from 1,300 to 18,700 in 2017. It's important that Congress protect the integrity of 340B and ensure the program will continue to serve low-income Americans in need of care. I look forward to hearing what the GAO found in its latest investigation and from our stakeholder witnesses on the importance of 340B. I think we can always improve the program. I'd like to add this record a statement from the American Hospital Association and the Association of American Medical Colleges in today's hearings.
Without objections, order.
Thank you, Mr. Chairman, and I yield the remainder of my time to my colleague, Congressman Matsui from California.
Thank you very much for yielding. I hope we can all agree that the 340B discount drug program is incredibly vital to low-income and vulnerable communities. Hospitals and clinics serve our communities every day. They are on the front lines of the opioid crisis right now, and this program supports that work. Unfortunately, there seems to be some misunderstanding about the original intent of the program. 340B was intended as a creative and flexible way to allow community providers to stretch scarce resources without using taxpayer dollars. It was never intended to be a drug discount program directly for patients. Rather, it is discount to providers so that they may better serve patients. For example, Ryan White HIV clinics can use the savings to truly address the social determinants of health surrounding medication adherence. That is not always direct medical care. Instead, it is a public health approach that addresses the barriers that keep people from taking their medication appropriately. I have concerns about some of the bills and drafts we are discussing today. No one has a problem with the concept of transparency, but I'm afraid that the true purpose of this legislation is just to narrow the scope of the program rather than to increase transparency. There is also very little discussion about drug manufacturer transparency in the program, despite the fact that only a handful of audits have been conducted on manufacturers, and the civil monetary penalties for noncompliance have not been implemented. The 340B program keeps drug prices lower for providers serving low-income and vulnerable patients. Changing the 340B program would do nothing to reduce high drug prices, as some claim. It is important to recognize a good thing when you have it, and the 340B drug discount program is exactly that. And that's why I authored H.R. 6071, the Serve Communities Act, which will codify the program's true intent, improve program integrity, and further extend it to mitigate the opioid crisis. I look forward to continuing to work with the committee to support the services provided by the community health providers. And thank you, and I yield back.
And the gentleman yields back.
Yes.
Chair, thanks, gentlemen. Gentleman from Oregon is now recognized, Chairman of the full committee, Mr. Walden, 5 minutes for an opening statement.
Well, thank you very much, Mr. Chairman, for holding this legislative hearing to examine ideas to improve the 340B program. Since its creation by Congress more than 25 years ago, the 340B program has helped provide life-saving medicines at reduced prices to certain safety net healthcare providers. Now, through this program, many providers have been able to reach more patients, serving more uninsured and underinsured patients due to the savings this program enables. The Health Resources and Services Administration estimates that in 2015, covered entities saved about $6 billion on 340B drugs through their participation in the program. For some participating healthcare providers known as covered entities, though, this program and the savings it generates are critical not just to their mission to help patients, but also it undergirds their financial viability and their ability to keep their doors open. And I've met with hospitals, I've met with health centers in Oregon, including those in Bend and Hermiston, among other locations, and they've told me about how they are using 340B savings to increase access to health care for the underserved. So it is really an important program. But it's important to note that a lot has changed since the program was created. The number of unique hospital organizations participating in the program has nearly quadrupled in just 5 years, from 3,200 participating hospitals in 2011 to 12,148 in October of 2016, so quadrupling in 5 years. While the actual number of 340B contract pharmacy arrangements unknown because it is not tracked, the Government Accountability Office has informed us that 1,645 covered entities had a total of 25,481 registered contract pharmacy arrangements. GAO warns this sprawling complex of arrangements increases the likelihood of covered entities being out of compliance with federal law. GAO's latest report follows others from nonpartisan auditors expressing concerns about a variety of issues that are a challenge to the integrity and the accountability of the program. For example, both HHS's Office of Inspector General and GAO have identified the lack of a clear definition of the 340B patient as a structural challenge to HRSA having clear rules of the road. We've also heard serious concerns from stakeholders. Because the 340B program does not specify how program savings must be utilized by a covered entity, many have questioned whether or not all covered entities are sufficiently transparent with how their participation in the program ultimately benefits patients. Others suggest this program is in need of a tune-up. Regulations need to be finalized, rules of the road need to be made more clear, audits need to be more comprehensive, and enforcement needs to be more consistent. There are also reports following the committee's 2-year investigation by our own Oversight and Investigation Subcommittee. That report detailed a lack of oversight, a lack of reporting requirements, and a lack of reliable data. Earlier this week, HHS Secretary Azar spoke about the department's plans to move forward with finalizing regulations that have been repeatedly delayed. I'm encouraged by his comments. but also know there's more HHS should do to improve the oversight and the operations of this program. Our committee has an important responsibility to carefully evaluate a number of ideas from members on both sides of the aisle about how to improve this program. I fully expect my colleagues will bring different views and ideas forward in examining these bills to improve the 340B program. I hope we'll examine the bills from the shared premise that we all want to ensure some of our most vulnerable patients receive the care that they need and that they deserve. Finally, I'd like to highlight one bill in particular. That's H.R. 6273. It's a bill I've introduced along with Representative Mimi Walters. This bill would require 340B DISH hospitals that have an emergency department to establish a plan for getting victims of sexual assault access to a sexual assault forensic examiner facility so they can be properly examined and treated by a qualified health provider. I'd also like to highlight Mission Health Systems in North Carolina, who told us how they're already using their 340B savings to provide care and examinations to sexual assault victims. And Mr. Chairman, I request that this letter from Mission Health Systems in North Carolina be entered into the record.
Without objection, so ordered.
So I'd like to thank our two panels of witnesses for being with us today. I appreciate your feedback on these pieces of legislation. We know we have a lot to discuss, and we'll learn a lot by your testimony as we work to strengthen this program in a bipartisan manner. And with that, Mr. Chairman, I'll yield back and give the caveat that I think we have multiple hearings going on, and so I have to jet between them and a meeting over in the Capitol. But we do appreciate your participation in this. We want to get this right and modernize this program. Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Chairman. Chair now recognizes the gentleman from New Jersey, Mr. Pallone, the ranking member of the full committee, 5 minutes for an opening statement, please.
Thank you, Mr. Chairman. 25 years ago, Congress passed bipartisan legislation establishing the 340B program, and since that time it has played a critical role in ensuring that low-income and vulnerable individuals have access to affordable health care. Congress created this program with the intention of helping healthcare providers expand their capacity to serve low-income, uninsured, and underinsured patients in their communities. By purchasing drugs at a discounted rate, 340B providers can stretch resources to provide more comprehensive health services, and after all, many of these drugs have experienced dramatic price increases over the years. So I commend the work that our hospitals, community health centers, and all our safety net providers do, and make no mistake about it, they do a lot. What I do not support is the process for this hearing. It is not thoughtful, it is not bipartisan, and it is not productive. Having one hearing for a 65-page GAO study and 14 bills, many that are drafts that were given to us just days ago, is ridiculous. We should be working closely with each other and with stakeholders on such an important issue. First of all, the GAO study should have a hearing on its own. Second, we should have had actual witnesses who are part of the 340B program who run the program that can give their expert opinions on the consequences and effects of these policies. Today's hearing is counter to the purpose of why we hold legislative hearings at all. Democrats are clearly interested in working to strengthen the 340B program, but this is certainly not the approach I would take to find bipartisan consensus. In the past, I've worked in a bipartisan fashion to try to address the concerns from stakeholders on all sides of this issue in a balanced and measured fashion to strengthen and support the mission of 340B. But it's simply too difficult to be appropriately substantive with this many items before us in so short a time frame. Now that said, let me comment briefly on some of the bills. I want to commend Representative Matsui for her leadership on H.R. 6071, the Serve Communities Act. This bill would ensure balanced oversight of both 340B covered entities and manufacturers. It would also ensure that HRSA implements the regulations they were required to issue 8 years ago and includes many other provisions that would strengthen the program. There are also bills that would enhance 340B operations and give HRSA more resources and authority to operate the program and collect covered entity and manufacturer information. This is an example of an important area where we could have a realistic conversation about strengthening the 340B program had this process looked a little differently. As the investigation of our Oversight and Investigation Subcommittee found, the 340B program is working as intended. Savings on the cost of outpatient prescription drugs makes it possible for these providers to shift resources to services that benefit the entire community. Services such as offering primary care clinics at little to no cost, delivering medication to patients with limited transportation, and maintaining a traveling children's dental clinic. It was clear from the responses we received from the 340B providers they're using their savings to serve the community, and Congress should commend and support these efforts. Limiting the 340B program would severely undermine covered entities' ability to support this critical work. That's why I do not support legislation that would curtail or restrict the program. Legislation like H.R. 4710 that includes a 2-year moratorium on new hospital enrollment in the program is unnecessary and unfounded. Or the Protecting Safety Net 340B Hospitals Act, which would not actually protect anyone at all. Instead, this bill would lead to the termination of 573 DSH hospitals. That's 51% of all DSH hospitals currently enrolled in the program. I would note that these hospitals provided roughly $10.8 billion in uncompensated and unreimbursed care. If this bill ever became law, nearly 75% of our states would see 50% or more of their DSH hospitals cut from the program, with 5 states having all their DSH hospitals cut from the program. And these types of bills are not about improving or strengthening 340B. They're about gutting the program, which I obviously will not support. Instead, I remain dedicated to finding ways to strengthen the 340B program and ensure that it continues to fulfill its vital mission. I yield back, Mr. Chairman. Thank you.
Chair thanks the gentleman. The gentleman yields back. This concludes member opening statements. All members are reminded that their opening statements will be made part of the record. Certainly want to thank our witness for being here this morning, taking time to testify before the subcommittee. So we have 2 panels of witnesses, and each witness will have an opportunity to give an opening statement. This will be followed by questions from members. On the first panel today, we'll hear from Ms. Deborah Draper, the Director of the Healthcare Team, the United States Government Accountability Office. We appreciate you being here with us this morning, Ms. Draper. You're recognized for 5 minutes for the purpose of your opening statement, please.
Chairman Burgess, Ranking Member Green, and members of the subcommittee, thank you for the opportunity to be here today to discuss our recently issued report on the use of contract pharmacies in the 340B program. We're going to be projecting some slides to go along with my opening statement so that to provide some illustrative examples. So the 340B program requires drug manufacturers to provide discounts on outpatient drugs to certain hospitals and federal grantees, also known as covered entities, to have their drugs covered by Medicaid. A covered entity typically dispenses 340B drugs through pharmacies, either in-house pharmacies, through contracts with outside pharmacies, or both. In March 2010, HRSA lifted the restriction limiting the use of contract pharmacies, allowing any covered entity to contract with an unlimited number of pharmacies. As a result, the number of contract pharmacies increased significantly from 1,300 to 20,000. For our report, we examined a number of issues. We first examined the extent to which covered entities contract with pharmacies to distribute 340B drugs. We found that about a third of the more than 12,000 covered entities in the program had at least one contract pharmacy. The number of contract pharmacies ranged from 1 to 439, with an average of 12 per covered entity. Compared to other covered entity types, hospitals were more likely to have contract pharmacies and have a larger number of them. The distance between covered entities and their contract pharmacies ranged from 0 to more than 5,000 miles, with a median distance of 4.2 miles. Second, we examined the financial arrangements that covered entities have with contract pharmacies and third-party administrators related to the dispensing of 340B drugs and program administration. Of the 30 contracts we reviewed, we found that covered entities generally pay their contract pharmacies a flat fee ranging from $6 to $15 per 340B prescription. Some covered entities paid additional fees based on a percentage of revenue. We also found that covered entities reportedly paid their third-party administrators using one of 2 main payment methods, either per prescription processed or per contract pharmacy. Third, we examined the extent to which covered entities provide discounts on 340B drugs dispensed by contract pharmacies to low-income, uninsured patients. We found that 30 of the 55 covered entities responding to our questionnaire reported providing discounts at some or all of their contract pharmacies, with federal grantees more likely than hospitals to provide discounts. And finally, we examined HRSA's efforts to ensure compliance with 340B program requirements at contract pharmacies. We found that first, HRSA does not have complete data on all contract pharmacy arrangements, which is critical to informing its oversight efforts, including audits of covered entities. Specifically, HRSA does not require covered entities to specify which of its sites have a contractual relationship with each pharmacy. Second, HRSA's audits identified a number of issues at contract pharmacies. However, the audits understate the extent of the noncompliance with the 340B program prohibition on duplicate discounts for drugs prescribed to Medicaid beneficiaries because they do not assess the potential for duplicate discounts in Medicaid managed care where the majority of beneficiaries are enrolled. Third, while HRSA requires covered entities with noncompliance issues identified during audits to assess the extent of the noncompliance, it does not provide guidance as to how these assessments should be made, nor does it review the methodology used. Fourth, HRSA does not require most covered entities to provide evidence that they have taken the necessary corrective actions and are in compliance with program requirements prior to closing an audit, relying instead on entities' self-attestation of compliance. And lastly, HRSA's guidance on contract pharmacy oversight lacks specificity, providing covered entities considerable discretion on the scope and frequency of their oversight practices, with some performing very minimal activities. In conclusion, we made 7 recommendations for HRSA to strengthen its oversight of the use of contract pharmacies in the 340B program. HRSA did not concur with 3 of these, stating that implementation would be burdensome for covered entities and the agency. We disagree and believe that the implementation of these recommendations is critical to improving the integrity of the program. There are also 2 additional points that I wanted to make. First, it is critical that HRSA ensure that it has the necessary oversight infrastructure and resources when making major programmatic changes, such as lifting the restriction on the number of contract pharmacies. And second, it is essential that HRSA optimize the value of its oversight activities, including audits of covered entities conducted through a contract costing nearly $4 million annually. Mr. Chairman, this concludes my opening remarks. I would be happy to answer any questions.
And our thanks to our witness this morning. We'll move to the question and answer part of the hearing, and I'll recognize myself 5 minutes for questions. So I have the report that GAO published and the recommendations for executive activities. Let me just ask you, on the issue of the contract pharmacies, is there any evidence, and this program was expanded, correct, in early March of 2010? Your microphone may need to be on.
Prior to March 2010, an entity was allowed to have a contract pharmacy if it did not have one contract pharmacy, if it did not have an in-house pharmacy. After that, the restriction was limited so that entities could contract with an unlimited number of pharmacies.
So do we have evidence that increasing the number of contract pharmacies has happened in 2010? Do we have evidence that more patients now are reached with the increase in the contract pharmacies as they were expanded in 2010?
Yeah, that's difficult to monitor, but I mean, HRSA would say that one of the reasons for lifting that restriction was to increase access points for pharmacy for patients. We also know that there's, it does create some oversight issues around the rapid increase in the number of contract pharmacies, as we know from the audits that a lot of the issues around diversion are really related to diversion at contract pharmacies. So of the 813 audits that have been conducted, there were 380 incidents of diversion found in those audits, and 249 were at contract pharmacies.
And is it the concern that when the expansion occurred in 2010, there was not a commensurate increase of resources for HRSA to be able to adequately monitor that?
For HRSA, the group that oversees the 340B program or administers the program is a very small group it's a very small group, and they really haven't had any major increases in staffing related to, not commensurate with the increase in the number of covered entities and contract pharmacies through the years.
So is it safe to say they're still at 2010 levels as far as their funding, or their resources?
I don't believe they're at the 2010 level, but they're not far from that. So they made some increases, but they're still a very small shop.
So of your 7 recommendations, and again, thank you for providing those, recommendation number 2 is one that certainly caught my eye about the duplicative discounts under Medicaid managed care. So obviously there are unintended consequences of not having the guidance that has been recommended. Are there currently any incentives to encourage states to oversee the 340B program in their managed care environment?
Well, currently, there is no, HRSA has not issued guidance on how to handle duplicate discounts in Medicaid managed care. Now, there's 60% of the Medicaid drug spending currently in Medicaid is in the managed care program. 70% of the Medicaid prescriptions are written for Medicaid managed care beneficiaries. So it is where the bulk of the beneficiaries are enrolled, and where the greatest level of activity is located in Medicaid managed care. And when we were doing our audits, we did find evidence that there was, there's evidence of duplicate discounts. In one of the audit files we found, there was a letter from a state that recognized that there was duplicate discounts were found in Medicaid managed care. And because there's really no guidance at this point from HRSA, it's not clear to covered entities how they're supposed to handle that. And it also creates, I think, issues for manufacturers who, it puts them in the middle of whether they go after the state or the covered entity to regroup to reclaim the duplicate discount. So it creates a lot of different issues.
And just to be clear, when we're talking about duplicate discounts, we're talking about discounts in the 340B program and discounts in the Medicaid drug rebate program?
That's correct. And it is a prohibition in the 340B program that the covered entities are not to subject manufacturers to duplicate discounts.
But there is a concern that it may be happening, and it would not be intuitively obvious to the casual observer because of the structure of a Medicaid managed care contract?
I would say it's unclear to the extent that it's happening. I know that it's happening to some extent, and I think that the entities that we talk with express concern. It's anecdotal evidence, but they express concern about the extent to which this is happening and how they're supposed to address it.
I can see how it could be completely unintentional if you have a capitated contract with an MCO, and you also have a discount. How do you allocate whether that discount is coming from the 340B program or the Medicaid drug rebate program? So I can see how just the bookkeeping could be difficult and an unintentional violation could occur. But do you think it possibly is more than that?
It's hard to say. I think that that was why we made a recommendation. HRSA will need to work with CMS to provide guidance on how to deal with potential duplicate discounts in Medicaid managed care. It has not yet happened, and I think it's something that's really important that needs to happen. And as you noted, that was one of our recommendations.
And I agree with you. Concludes my questions. Mr. Green, you recognize 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Draper, thank you again for your excellent work on this issue, and I'm particularly interested in the discounts provided for drugs to low-income and uninsured patients. While 340B is not a program based on actually giving discounted drugs directly to patients, I think it still wouldn't sit right with most people to think about anyone gaining revenue from people that need medications and cannot afford them. Regarding 3 of the GAO recommendations, HHS disagrees, says that they don't have enough resources, and 2, the requirements would be significantly burdensome on covered entities, especially smaller providers such as federally qualified health clinics. In your report, did you examine whether it's a major hospital system or a community health center, the difference in how they would comply with that?
So they disagree with 3 of our recommendations, one of which was the extent, the first one was to register all their contract pharmacy arrangements. So that would mean that they would register each or have some record of each, besides the parent entity, each child site as well that has a relationship with each pharmacy. They said that would be burdensome. Our point was that they already require that when they register their when they register their entities. So we didn't feel like that was really an excessively burdensome task to be done. So that was one issue that they had. The other issue that they didn't comply with or didn't concur with is that looking at when we talk about the extent of noncompliance, looking at the methodology used and the extent of noncompliance, and so what they talked about was that they thought that would be administratively burdensome. The entities, when there are issues of noncompliance that come up, they have to do a corrective action plan. So really, that information is detailed, and what we were asking for is just additional information about specific methodology and how that was reviewed. So we didn't feel like that was excessively burdensome.
Didn't some covered entities then proactively note some of the other ways they care for patients? Isn't it true that some covered entities that do not provide discounts on 340B drugs at their contract pharmacies actually, for instance, provide free or discounted prescription to elsewhere and oftentimes broader free medical care? The GAO's report on 340B contract pharmacies was published last month. HHS disagreed again with those recommendations. And again, it seemed like they did a blanket rejection of the recommendations. But I think our subcommittee and the committee can decide what needs to be done. But again, HHS is the one who deals with that on an everyday basis. So we need to. HHS stated that many of the GAO's recommendations impose significant burden on covered entities, especially smaller entities which over-resource constrained. That's why I said it's different between a 5-hospital system and a federally qualified health clinic that may only have one facility or maybe 2 or 3 and on a much smaller scale.
And to answer that partly as well is that most of the covered entities that have child sites, they're going to be the larger entities. These are going to be hospitals and federally qualified health centers. Most of your smaller grantees are not going to have child sites. So really, these are larger entities that most likely have the capacity and the capability to have the resources to do what we're asking to do.
Since HRSA implemented a systematic approach to auditing covered entities in 2012, has oversight of the 340B program improved?
Well, the implementation of the audits came as a result of our 2011 report and recommendation. So we believe that the audits have been beneficial. I think one of our concerns is that, in 2012, so for the last several years, they have audited 200 entities annually. And that represents about 1.5% of total covered entities. So the pace of the audits it's not keeping pace. The number of audits are not keeping pace with the growth in the number of covered entities. They have found quite a number of issues with diversion, duplicate discounts, and also some entities not providing the oversight of their contract pharmacies as they're supposed to.
Do you think it's part of the oversight for 340B would improve if Congress appropriated additional funds for HHS for those specifically for those purposes?
Well, it's difficult to say, but my thought is that probably resources are an issue about why the number of audits haven't been expanded. They have a contract with that they've had in place for the last 2 years for a contractor to conduct the audit. So, they do have limited resources, so I would expect there's probably something to do with resource limitation around, whether or not they're able to increase their oversight activities.
Thank you, Mr. Chairman.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes a gentleman from Kentucky, Vice Chairman of the Health Subcommittee. Mr. Guthrie, 5 minutes for questions.
Thank you. Thank you, Chairman. Thank you, Ms. Draper, for being here. And you touched on some of this in your testimony. I'll give you a chance to kind of expand. So in your testimony, you stated that the number of contract pharmacies increased from 1,300 in 2010 to approximately 20,000 in 2017. Why do you think the number of contract pharmacies increased dramatically within this time frame, particularly in the last couple of years?
Well, it really has to do with HRSA lifting the restriction about having, lifting the restriction to now allow covered entities to have an unlimited number of contracts with pharmacies, outside pharmacies.
Okay, and then based on your knowledge of these types of contracts between covered entities and pharmacies, do you think HRSA should regulate how contract pharmacies are paid?
Well, HRSA has no legal authority over that, and they will tell you that it is a private business decision between the covered entity and both contract pharmacies and cases where they use a third-party administrator as well as with third-party administrators.
Well, yeah, I understand they don't have any legal authority, but that would be something we would look to address. Do you have an opinion on that, whether it should be regulated by
Well, it's
HRSA?
an interesting question because in their comments to us, when they were responding to our report, they were very concerned. We looked at 30 contracts and looked at the financial arrangements between covered entities and their contract pharmacies and third-party administrators, and HRSA was very concerned about us publishing the payment rate information, that information had never been made public, and they were concerned about it being disruptive to the drug pricing market and would cause fluctuations in the prices charged for covered entities. We disagree because the sample size was pretty small, 30, but I think it would be something that probably would need to be addressed if you're thinking about more broadly making that more transparent across all contracts.
Well, in your study, did you notice or see, or could you identify any best practices in payments that probably should be adopted across the board?
Well, we saw wide variation, so it's really difficult to say, and we really didn't look at the impact. So we looked at the financial arrangements, but not what at the back end what were the most effective.
Okay. Well, thank you, and that does conclude my questions. I know I have 2.5 minutes. I will yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the lady from California, Ms. Matsui. 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Draper, GAO asserts in the report that the study was conducted in part because the number of pharmacies that covered entities have contracted with has increased a substantial amount since 2010. I know we've been having that discussion. Now, critics do cite similar statistics saying that the program has exploded because the number of covered entities has increased since 2010. And I would just like to set the record straight that Congress intentionally expanded the 340B program in the Affordable Care Act. We recognize the success of the program in allowing hospitals and clinics to better serve their communities, and we extended that success to rural hospitals, which I believe is really very important. I want to talk some about the audits here. Much of this GAO report uses data recovered from HRSA audits of covered entities. Dr. Draper, is that correct, yes or no?
Yes, our report talks about covered entities audits.
Okay. How many audits did you find HRSA conducted on covered entities from 2012 to 2017?
There were 831 conducted. In the last few years, it's been 200 each year.
So a total of how many?
Out of 12,000 entities. So it's
Okay.
about 1.6%, 1.5% of total covered entities.
Okay. So in your work at GAO studying the 340B program, have you received any audits of drug manufacturers in the program?
We have not done that work, no.
And why is that?
We've not had a request or a mandate to look at that issue.
So we should request that be done if we wanted to have that done. Is that correct? Because my records show that there were less than 20 audits of drug manufacturers in the history of the program.
Yeah, actually there were, I think Dr. Pedley said at a recent hearing that there have been 12 conducted to date. There was one in 2015 and 5 in each of the years, 2016 and 2017, and I think they're on tap for doing 5 this year. And according to the website, there have been no findings related to, they've had no findings on those manufacturer audits.
So,
But out of 600 manufacturers, it's about 0.5%.
okay, so we've had many audits on the covered entities, but very few or nothing on the drug manufacturers then.
Well, compared 831 versus, I guess, 12 have been completed.
Yeah, right, okay. Does HRSA require that drug manufacturers take corrective action if found in noncompliance with program requirements?
That's correct.
Okay. Since GAO's 2011 recommendations, has HRSA taken steps to improve its oversight of covered entities in the program, including a systematic approach to conducting audits of covered entities?
Yes.
Okay. Has HRSA taken any steps to improve oversight of drug manufacturers in the program?
Again, I can't answer that. We haven't looked at that issue.
Okay, and I understand that you have not studied this, or made any recommendations, and I would think that we should plan to have more oversight on the drug manufacturers if we're going to be looking at the contribution of drug manufacturers and also the use from the covered entities.
And that may be some potential work that we do in the future.
Okay, great. Mr. Chairman, I'd like to ask unanimous consent to submit a few letters for the record. The first is a letter to leadership from a long list of patient groups that emphasizes the importance of the 340B program for people living with diseases like hemophilia, HIV/AIDS, epilepsy, hepatitis, mental illness, lupus, and more. And I also have letters from 340B Health, a long list of doctors from across the country, and the American Society of Health System Pharmacists, again emphasizing the importance of the program.
Without objection, so ordered.
Thank you, and I yield back.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Texas, Vice Chairman of the full committee, Mr. Barton. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you for holding this very important hearing. You know, there's a saying that a lot of us use quite a bit. It's called "No good deed goes unpunished." The 340B program was set up to be a really good deed, and word spread, and now, in my opinion, that program's being abused. In the report that GAO did, they claim that the number of hospitals that are participating in 340B is up to 12,722, and it's tripled in the last 4 years. And the report further states that that's about 40% of the hospitals. But according to the American Hospital Association, there are only 15,598 hospitals in America. So if the AHA number's right, 82% of the hospitals in the United States are now participating in the 340B program. This is a program that's supposed to help lower drug costs for hospitals that serve a disproportionate share of low-income patients or patients that participate in low-income Medicare and Medicaid. It's obvious that, to me anyway, this program is being abused. So the question is, what do we do about it? Well, in a perfect world, which this is not, the Republicans and the Democrats on this committee would work in a bipartisan basis, and we'd come up with a solution. And there's a chance, Mr. Chairman, that we may actually do that. I don't know.
Will gentlemen yield?
I'll be happy to yield.
Hope springs eternal.
Hope
Yield
springs-
back.
Okay. And I'm a hopeful guy, Mr. Chairman. But in any event, I've, with committee staff, have put forward a discussion draft that says one thing we could do is just raise the percentage of disproportionate share patients that the hospital serves. And like we're going to have Parkland Hospital, which is a low-income hospital for Dallas County and Dallas, Texas. Their chairman's here in the next panel. They serve over 50% of their patients would qualify. Current law says you only have to have 11.75%. So the discussion draft says, let's raise that percentage to a little over 18%. I don't think that's a draconian increase. Now, I could be wrong, but let me ask you, ma'am, do you believe, based on the study, that it would be good public policy to raise the DSH percentage requirement a little bit, or maybe a lot?
Well, I've testified on this several times before. I think a major issue with this program is that the intent of the program is not very clear. The intent was set up when the program was first set up in the early 90s. A lot has changed in the healthcare landscape over that time, and whether that intent is still relevant today, I think that is something that is one of the first things that need to be done, because a lot of people assume that it's a program for low-income people. That's not explicit in the intent, and so then that gets to the whole issue about discounts and whether discounts are supposed to be provided. And
Well, is there any question that the intent was not to let every hospital in America participate?
well, at the time, I think it was more that, the intent was really, to me, closer to what a covered, like a grantee. It was to stretch scarce federal resources to provide more comprehensive services and reach more patients, really using the federal grants that were available to the covered entities at the time.
Well, I agree with you. The intent was not clear. There's enough ambiguity in the program, you can drive a Mack truck through, and word's gotten around, and not every hospital, there's still 18% that apparently don't read the newsletters.
Well, the 12,000, I think, if you're talking about the 12,000 covered entities, that includes both hospitals and federal grantees, so it's not just hospitals. The hospitals are probably a little bit more than 50% of that number, and the federal grantees are the remaining.
So the 40% number,
It's probably 40, the last number I saw was 45%,
so pure hospitals would be 6,000.
something along
like
that
that.
lines.
Okay. Well, my time's expired, Mr. Chairman, so I'm going to have to yield back. But I think it's good to have this, and I think it's very good that we try to work to tighten up, and as the gentlelady just said, let's determine what the real intent is and then legislate accordingly. With that, I yield back.
Chair, thanks, gentleman. Gentleman yields back. Chair recognizes the gentlelady from Florida. 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Draper, I want to return to GAO's recommendations on the audit process for 340B covered entities. These recommendations appear to create a lack of parity between HRSA's audit process for covered entities and the agency's audit process for manufacturers. For instance, I do not think that HRSA has any requirement or guidance regarding how long manufacturers must look back for 340B overcharges, nor are manufacturers required to submit any documentation demonstrating that an error leading to 340B overcharges to covered entities has been corrected. Did GAO consider this lack of parity in manufacturer audits when they were constructing their recommendations?
We did not, because the scope of this work really related to contract pharmacies, the use of contract pharmacies. And, we haven't done, as I mentioned earlier, we have not done work looking at audits of manufacturers. And, HRSA does post that on their website, and as I said, I think they've talked about 12 completed to date.
So GAO that wasn't in your scope this time, and then that hasn't been a focus in the past at all?
Right, it hasn't been a focus. The audits of manufacturers, from my understanding, started in 2015. So this most recent report that we did really looked at the use of contract pharmacies in the 340B program.
So you would need the Congress to suggest that would be a good idea if we're going to do it?
We do our work either through mandate or a congressional request.
I just think it's an important piece of it because it seems like something is afoot here, that the manufacturers have and drug companies have really been playing offense when it comes to 340B, and I think it would be fair to take a look at their overcharges. I mean, this is, we're struggling right now in America with how to contain these huge cost increases for drug prices. When I'm at home and I sit down with my neighbors and talk and ask them what's important, this is always the top of their list. And it's a little bizarre to me that the committee's having a hearing on this rather than really doing a much broader look at how we contain the escalating cost of prescription drugs for folks. There are some great Democratic bills out there. We've tried to get some Republican support, but it's just, there seems to be a real disconnect here. The 340B it's so vital to my hospitals. It's the one initiative out there that helps our safety net hospitals and community health centers provide affordable prescription drugs. And it seems like the big drug manufacturers and drug companies they're never satisfied. And I don't know why we're taking up a great deal of time. I appreciate GAO's work. It's important. You can always improve certain initiatives, but it really gives me pause that this is the direction of the committee rather than really tackling the bigger issue for folks back home, which is much broader, much more severe. And I know you all are hearing it like I'm hearing it. So thank you again.
Yeah, I would just want to add that I think, clarifying the roles, rules, and responsibilities of all the stakeholders in this program is really critical for this program to have this program to be of the highest integrity. And I think that, the growth in this program, the pace of the oversight has not kept pace with the growth. And I think there's a lot of ambiguity and lack of transparency in this program that, improving those will go a long way to helping improve the integrity.
I agree with that. I agree with that strongly, because we have to protect program integrity because it is so vital for folks back home, and it enables our safety net hospitals and community health centers to make sure that they are serving their broader mission. But I'm talking about the larger context. So I appreciate GAO's work here, and really, I would hope the committee would be bolder in tackling this critical problem for our folks back home in their pocketbooks. Thank you. I yield back.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Illinois, Mr. Shimkus, Vice Chairman of the Energy Environment Subcommittee. 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate you being here, and I appreciate your opening statement. There is a concern in why it's important, because in your opening statement, we saw hospitals grow from, I think, 1,300 to 20,000 people in the program. We saw contract pharmacies go from 1 to 439. I just was scribbling based upon your opening statement. The distance of contract pharmacies from 0 to 5,000 miles away from a hospital. I don't know what the 30 to 55 was. I also wrote down that there was, and I was going to get the definition of diversion, which is not knowing who the drug pricing really follows, from what I understand, and trying to get staff definition, and no patient definition. Is that all part of that opening statement, Ms. Draper, that you said?
Yeah, the patient definition is pretty ambiguous. So
if you want to serve underserved, if you want to serve people who can't afford it, it might not be bad to ask the person.
Well, one of our recommendations from 2011 that still remains to be implemented is to clarify the eligibility criteria for a patient.
And that's why I'm not adverse to talking about and getting in this debate. Listen, I'm from rural, small town America. I have hospitals that rely upon this because of the patient area and who they cover. They're unafraid about being in this debate because they know they're covering the right people. The question is about the other ones and the expansion and getting some type of confidence. I got a letter from a state rep who talks about evidence of taking advantage of a system for their financial benefit and not properly serving vulnerable uninsured populations. We ought to look into that. This is a state rep, Charlie Meyer. This was sent in September of 2017. I have a letter from a pharmacist who's concerned about disproportionate hospitals, or what he says, these pharmacies will bill the patient's private insurance at usual and customary pricing, but can fill that prescription using 340B medications at significantly lower cost, kind of like gaming the system. The challenge in healthcare policy is that the national government, we're a big payer, Medicaid, Medicare. We also, with Medicaid, we participate with the states, but we always really underpay. So then healthcare providers try to find other ways to make up the cost. And that's maybe billing higher to private insurers and all this other stuff. And I think that's kind of what's going on here to some extent. There's another way for hospitals to make up the shortfall from the federal government not compensating. And it is right that we look into this and follow this discussion, this debate. So a couple questions in my time remaining. In your report, it states that 69.3% of hospitals versus only 22.8% of federal grantees had at least one contract pharmacy arrangement. Why do you think that is?
Well, hospitals are much larger. They serve, their catchment areas are much larger probably than federal grantees. They also have much more complex organizational structures, and they're more likely to have, than some of the grantees, have, multiple child sites that may be, far distance from where.
Could it be that the grantees have in-house pharmacies?
Well, they could, yes.
And I think that's probably something we should look at. The report states that some covered entities maintain contracts with pharmacies that they do not use to dispense 340 drugs. Why would a covered entity maintain this arrangement?
Yeah, that was an interesting finding for us. And what the covered entities talked about, like when there are very expensive drugs, like for hepatitis C or hemophilia drugs or HIV, that what happens is even if a patient rarely needed it, maybe once every 2 years, that it was more advantageous to keep that arrangement in the case where that one patient might need that very expensive drug.
And I think you answered this before, but just for the record, before registering contract pharmacies with a given covered entity, does HRSA review the covered entity's plans for oversight to ensure it is sufficient?
They do not, but they will collect those policies and procedures if they conduct an audit of the covered entity. So at that point, they'll pull the policies and procedures and look at those.
I appreciate your testimony, Mr. Chairman. I yield back. Thank you very much.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Oregon, Dr. Schrader. 5 minutes for questions, please.
Thank you, Mr. Chairman. I appreciate it. I appreciate Mr. Rayburn being here and work that GAO does. A question that came up in the hearing so far about, why do we have this program? And I think it's pretty clear, frankly. It was established back in 1992 and supposed to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. End of discussion. Now, if we don't think that's the appropriate use of the resources of the discounts, then let's have that discussion. I'm okay with that. But I think it's pretty clear that the goal of the program is to, frankly, allow people and allow modern medicine to use the discounts from some of our pharmaceutical friends who save millions and millions of lives in a much more conducive and setting than being in a hospital by making sure people have access to these medications, that we should embrace that. I mean, that's a good thing. The other piece that I'm a little concerned about in the tone of the conversation so far is that having this vast increase in people using the 340B program is wrong. I'd argue that's a success. It means that hospitals are beginning to realize, especially with the advent of the Affordable Care Act that broadens services to a lot of very vulnerable people, that there's an opportunity for them financially and for them from the standpoint of their Hippocratic Oath providing excellent care to my constituents, that they are able to do those wraparound services. We don't have the money in our system right now to give these folks the opportunity to develop this wraparound service, and it's paid for largely, or at least some of it, out of the 340B discount program. And what population is served by that is not specified, although I think your audits show, hopefully for the most part, it seems like, at least in my state, that the program is being used appropriately. The discounts are on drugs for those people that are eligible. I think that's great. So far in my state, I'm not aware of a lot of problems. We've had some audits. I met with some of my providers just a few weeks ago, and they've been recently audited. They seem to be indicating they're getting audited on a little more regular basis than you've talked about so far, and they're meeting their goals. So I'd argue respectfully that since we do have a lack of resources, well, fairly significant lack of resources here in Washington, D.C. to help our hospitals deal with our Medicaid population and those other low-income folks where this wraparound service prevents them from coming in and actually costing the system and the taxpayer a lot more. And that's a discussion I think we have to have a little more of before we start adding new rules and regulations. I came in a little late, and I apologize for that, and haven't gotten through the entire report. But what was the finding in terms of duplicate discounts by the different hospitals and covered entities? They're not supposed to have a Medicaid rebate discount and take 340B. What was the finding in that regard, Ms. Draper?
Well, there is evidence that there are duplicate discounts in Medicaid managed care, and HRSA will say that they haven't issued guidance to covered entities. Covered entities express concern that that may be occurring, but they don't really have guidance as to how they handle it. Most recently, HRSA added a change, so if they become aware of a potential for duplicate discount in one of their audits, They will put it in the audit finding letter, but they will not require the entity to really do anything about it unless there are other findings related.
So I'd like
to
to see
audit.
those specific instances from your report identified, what percentage of the hospitals there's other entities too. Hospitals are a smaller percentage of the covered entities that the program applies to. So I'd like to see, if it's possible, where you found that, and also if there's some geographical differences. It was
So we
more
did,
prevalent.
this was based on 20 completed audits, and we found it in one of the files.
1 out of 20.
Out of the 20, yes.
All right, well,
And then HRSA.
your
HRSA's
point
aware
earlier,
that-
I think we need to do more audits. It's hard to get statistically relevant with information out of 18,000 or 16,000 covered entities or
Right,
hospitals.
I think the other issue is that, the majority of beneficiaries in Medicaid are in managed care, so that is an important place for, that.
Last question, I'm sorry, I'm running out
that's
of
okay.
time, and that, you talk about an increase in 25% of the discounts paid. What portion of that is a result of the increased cost of pharmaceuticals over the same, time period from 2010 till now?
The 25% increase in cost paid?
Yeah, and
Well, we look at you have to look at the proportion of the cost.
I mean, if the program is costing us 25% more since 2010, some of that is obviously increase in popularity. People are realizing they can actually do that nice wraparound service. The other piece is, potentially increased costs as a result of new age drugs that are, again, maybe very, very good. But I think we need to have that information, Ms. Draper. That would be really helpful for us to decide how much of this is appropriate and how much is not. So I'm fine with clarifying the rules. I think they're pretty explicit at this point, and make sure that everyone's following and being enforced. Do more audits that we currently are doing. They seem to be working. But I'd rather that than have a whole bunch more new regulation. Let's enforce what we already have. And I yield back.
Chair, thanks. The gentleman yields back. Chair recognizes the gentleman from Ohio, Mr. Lauda. 5 minutes for questions, please.
Thank you, Mr. Chairman and Director. Thanks very much for being with us today. If I could maybe just touch on some questions in the transparency area. In the report, GAO states that HRSA does not require covered entities to share contracts made with pharmacies to the agency. Do you believe that sharing this type of information for all contracts would improve program oversight?
Well, it's you're probably talking about tens of thousands of contracts, so it would be probably pretty burdensome. The other issue is that HRSA doesn't have legal authority over those arrangements. They discuss it as a private business matter between the covered entity and contract pharmacies and third-party administrators.
Well, let me follow up on that then. Should such contracts be made public to ensure that the financial arrangement between the covered entity and the contract pharmacy are consistent with the requirements and purpose of the program?
Well, as I mentioned before, HRSA was very concerned about us publishing the financial information from the 30 contracts that we reviewed, discussing that it could be potentially disruptive to the drug pricing market and cost fluctuations in the fees that covered entities paid. We disagree with that, but I think it's something that, if you're thinking about this on a larger scale, it's something that have to be looked at and probably include HRSA in the discussion about that, what their concerns are and whether they're valid.
All right. In the report, GAO states that the covered entities must have a plan with the contract pharmacy to ensure compliance with the statutory prohibitions on the 340B diversion duplicate discounts. Should Congress require such plans be made public?
Well, currently HRSA does not require those unless they do an audit of the covered entity, and then they collect that information. I'm not sure what the public would do with that information. It would seem that would be something more important for HRSA to have rather than the general public. But that seems like an administrative process, oversight issue with HRSA.
On page 19 of the report, GAO states that the number of contract pharmacy arrangements is unknown because HRSA does not require a covered entity to register pharmacies with each of its child sites. And should such registration be required?
Well, that's what we recommended. So I can give you an example. So of the covered entities with one contract that register only one contract pharmacy, there were like 1,645 of those. They had 25,000 arrangements. So that could have resulted in more than 800,000, separate contract pharmacy arrangements. So HRSA does not have really that information, and it does go to inform, the complexity of the covered entities and the different arrangements that they have. It does inform their oversight efforts, particularly the audits of covered entities. It also makes it difficult for manufacturers to know whether a particular entity is actually included on the contract and it's a valid contract so that they can, actually provide the drugs to that entity.
Okay. What is the most important recommendation to improve the program integrity?
What's the most important one?
Right.
I would say all 7 are important. I mean, they all go to really program integrity.
Anything you'd list at the very top of as you were putting them in the report, 1 to 7?
I mean, it's really hard to distinguish because I think they all address different areas, but they all culminate in improving the integrity of the program, which is really critical. And I hate to say one over the other because I think they're all equally important. And we agonize over recommendations before we make them to make sure that they are valid. And so I would like to say that all 7 are important.
Okay. Well, as you're looking at the GAO side, on the HRSA side, how should HRSA prioritize the implementation of your report of the GAO recommendations?
Again, I think that they disagree with 3 of them, and we disagree that they disagreed. I think that they need to implement all of them. I think one of the big ones is the duplicate discounts. That needs to be clarified because no one knows the potential for the amount of duplicate discounts, and that's definitely a clear prohibition of the program. So I think that's one area, and that's going to probably require, they're going to have to work with CMS on that to get that implemented. So I think just the timeline for that and the importance of that would be one that I would probably focus on initially. But I think all 7 are important.
Right. Well, thank you very much, Mr. Chairman. I yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions, please.
Thank you, Mr. Chairman. Just remind everyone, 1992, no internet, and the Cold War was just ending. Times have changed, and the original intent of the program is important, but again, today is today. It's not 1992. I just want to make it clear that I'm a strong supporter of the 340B program. It's critical to many of the rural hospitals in my district. I called every CEO of every hospital, and honestly, all of them talked about the critical nature of the program, but also none of them had a problem with more oversight. You know why? Because they're doing what they're supposed to be doing. And if everyone out there is following the intent of the program, either original intent or in its current goals, then no one, I'll repeat, no one has anything to worry about with increasing oversight of the program, being required to report their activities. And those that are not, honestly, should be ashamed of yourselves, and you know who you are. It's ridiculous. As a provider, the intent of this is to get low-income fellow citizens access to very important, critical, life-saving medications. And so those of you who are opposing more transparency, the lady doth protest too much, methinks. So you can Google that and see what that means. But we know what the reason behind this is, okay? The reason is money. And so we need to get the focus off money and back onto the intent of why this program was put in place, and we've lost that. And it's appalling. Again, I want to say people that are fighting against more transparency, in my view, it's shameful. And they need to quit doing that and cooperate with the committee and help us improve the program for everyone. So, Ms. Draper, I mean, the reach has expanded way beyond and has led to the creation of, in my view, a cottage industry almost to maximize the profits, including vendors, software developers, consultants, contract pharmacies. Again, I know you've said this, but would you agree that further oversight of entities beyond the program's covered entities is warranted?
I would say there should be oversight of all the stakeholders in this program.
Agreed. So I don't think we have any partisan issue with that. From your perspective, considering the lack of transparency about the vendors, is there potential for program abuse there?
Well, I'd say
third-party vendors.
I would say when things are not transparent or the rules are ambiguous, that there's always it leaves a lot of interpretation and wide interpretation. So I think, if you don't have clear roles and responsibilities and rules, then, there is a lot to be interpreted, and it does pose a risk for potential undesirable effects.
Do you know how many third-party administrators there are?
I don't know.
You have no idea? And does the GAO have any information regarding how much money on average covered entities spend on contract pharmacies and vendors? Because these costs presumably could limit the amount of care provided to low-income and uninsured patients.
We don't have that information. That information, as far as we know, is not available.
So it's not transparent, so there's no way to know. And then the final thing I'll say is, I think you mentioned, that it's important to have transparency to HRSA. I'm going to argue that it's important to have transparency to the constituents that I represent. The only way that things change is if the people that I represent and every member here represents know what's happening out there. Things don't change, in my view, is if a federal agency understands better what's happening, because as you see, HRSA has said they don't agree with 3 of your recommendations, and you've made recommendations. When's the first time there were recommendations made about this program? I mean, what year do you think?
Yeah, we made recommendations in 2011, and they still have 2 yet to be implemented.
Okay, so that's roughly 7 years, right, depending on the time of year that they're implemented. So my point is, transparency to HRSA, to get more information to the federal agency, hasn't worked. It's not working, right? Nothing's been changed. Is that true?
Well, some things have changed, but, a lot of it is we haven't had this discussion about HRSA needing whether they can issue rules and responsibilities through guidance or regulation.
Right.
Their belief is that they need regulation. On the 2 open recommendations that we currently have, that they need regulation versus guidance.
Okay, and let me guess, they're blaming it on Congress, saying that we need to do a legislative fix. This is a classic agency approach where when they're not acting on recommendations from you or others, that they hide behind the quote-unquote legislative fix so they can't improve things. So my major push is this. In healthcare in general, not only in 340B, the only way that we're going to get healthcare costs down and ensure all of our citizens is if everyone in this industry is completely open and transparent to the people that I represent and to the people of America. Thank you, Mr. Chairman. I yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Missouri. Mr. Long, 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Draper, the GAO report indicates that disproportionate share hospitals have on average 25 contract pharmacies per hospital, with 45% have at least one contract pharmacy that is more than 1,000 miles away from the hospital itself. Your report also notes that guidance from HRSA, the Health Resources Services Administration, gives covered entities discretion on how to determine compliance for contract pharmacies. Could you discuss the effectiveness of covered entities' current oversight practices of contract pharmacies, given the lack of specific guidance from HRSA?
Well, when a covered entity contracts with a pharmacy, they are to have rules, specific policies and procedures how they're going to conduct that oversight. HRSA does not collect that information. They do collect it during the course of an audit. If an entity is audited, they will pull that information and make sure that they're in compliance. HRSA gives wide discretion about what that oversight means, and just for example, it says, their 2010 guidance says that the exact method of ensuring compliance is left up to the covered entity. So we found wide discretion about how entities are implementing, overseeing contract pharmacies. So for one example, one covered entity reported auditing claims of 5 randomly selected patients quarterly when they serve 900 patients on a monthly basis. And then one critical access hospital that serves about 21,000 patients annually, their independent audit reviewed 5 claims per year. So wide variation. I mean, there's no, again, this is, there's not specific guidance as to how entities are supposed to conduct oversight.
Yeah, well, that was my question. Excuse me. In your report, you also note that weaknesses in HRSA's audit process impede effectiveness of its oversight, namely that HRSA does not have complete data. How is HRSA able to determine that contract pharmacies are complying with program requirements?
Well, again, their audits are a major oversight mechanism.
What? I'm sorry.
They're audits of covered entities. So what happens is that when a covered entity contracts with the pharmacy, there's one of two ways that they can contract. One is that they can do a comprehensive contract, so the contract is with the covered entity and the pharmacy, and then if they're child sites, then all the child sites have to be listed on that one contract. The other method is to individually contract for each parent and child site with that covered entity. So that's one of two ways. That's how they contract. But when they register the pharmacies with HRSA, again, they can register the pharmacies per parent and child site, or they can just do a comprehensive, just register the parent site alone, which doesn't tell them who the individual child sites are. So they don't really have that information readily accessible in their records.
Okay. Grantees such as community health centers typically must demonstrate that they are serving a specific vulnerable population and are required to reinvest in additional resources into services for those populations. They also have substantial reporting requirements on how they use their funding. However, no similar requirement exists for hospital entities, even though we've seen a significant growth in the number of hospitals participating in the program. Would it make sense to put in place similar requirements for all participating entities?
Well, I can tell you that many of the grantees, they have specific requirements as part of their grants to how they use their revenue or savings and what discounts they might provide patients. There's not similar requirements necessarily for hospitals that participate in the program. So it's a difference between the two.
Okay. Do you believe the consistently stringent oversight across all entities is necessary for appropriate governance of the program?
Yes, I do.
Okay. Thank you. And Mr. Chairman, I yield back.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentleman from New York. Mr. Engel, 5 minutes for questions, please.
Thank you, Mr. Chairman. 340B is a small but essential program that lets qualified providers stretch limited resources to better serve their patients and communities. And in my district and at more than 100 New York safety net hospitals, 340B discounts allow for greater access to prescription drugs and more comprehensive care for patients, many of whom have nowhere else to turn. Now, I'm all for ensuring program integrity. It's essential if we want the 340B program to continue helping vulnerable patients get the care they need. And it's my understanding that hospitals are subject to random audits by the Health Resources and Services Administration to make sure that 340B is working as it should. Some of the policies we are considering today, though, don't seem to be aimed at better program integrity. Rather, it seems to me that the goal is really to make participation in the 340B program more onerous for providers or cut providers from this program altogether. And I'm concerned that with these policies to go into effect, providers would be forced to cut back on the care they offer to patients and curtail the work they're doing to improve the health of our communities overall. Now, this would come on the heels of the Centers for Medicare and Medicaid Services decision earlier this year to slash the amount Medicare reimburses for drugs purchased through 340B. In New York, this will result in more than $100 million in cuts to eligible 340B hospitals. That in turn leaves these providers with fewer resources to care for the same patients 340B is supposed to benefit in the first place. So I am a co-sponsor of Congressman McKinley's bipartisan bill to reverse these misguided cuts, and I hope this committee will act on legislation quickly. Dr. Draper, I want to ask about GAO's recommendations that HRSA should mandate additional registration requirements for contract pharmacies. It's my understanding that HHS did not agree with this recommendation, something that does not happen frequently, as there are already contract pharmacy registration requirements in place. HHS argued that new, needlessly burdensome requirements wouldn't do much to improve program integrity. I think we can all understand why contract pharmacies are important. Forcing patients to visit a hospital pharmacy when there is a more convenient option just doesn't make much sense. But I worry that the policies GAO has recommended would ultimately result in the loss of 340B discounts for eligible patients just because of where that patient chooses to get their drugs. And as a result, hospitals will lose out on savings that allow them to better care for these vulnerable patients. So, Dr. Draper, isn't it true that HHS had, quote, significant concerns regarding many of the findings in the draft report, unquote, and did not agree with 3 of the 7 GAO recommendations because they felt that it wasn't the best use of resources to actually improve program integrity?
They did non-concur with 3 of our recommendations, and the one that you were talking about specifically about registering, making sure that each site was registered with each contract pharmacy. They already have that information available in that part. When a covered entity registers their contract pharmacies, that information is available. It's just not available in their database. And the problem with that is that, they use that information to, the complexity of a covered entity is used in their decision about, 90% of their audits are risk-based audits, so they use that information, the complexity of an entity to determine which entities get selected for audit. So that's really important information to have. The other piece of that is that, it's important for manufacturers to have that information available to them, because if they don't have that, they're not really, they can't really verify that the entity that they're providing drugs for is really a covered entity under the contract.
Thank you. Thank you. I yield back, Mr. Chairman. Thank you.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from New Jersey, Mr. Lance. 5 minutes for questions, please.
Thank you, Mr. Chairman. Good morning to you, and thank you for your public service. As I have read your report, there is an indication that flat fees paid by pharmacies, paid to pharmacies by covered entities for brand name and specialty drugs were higher than going the other way. Does this make sense, and could you just explain that a little more to me?
Yeah, it may make sense because, those drugs are much more expensive. So, the flat fee for a generic, which probably is much lower cost, the thing that you want to do is make sure that the fees are proportional to the cost of the drug. So, I think there's been some talk about making the fees the same. And the problem with that is that then you might end up in that a patient pays more for being in the 340B program than if they weren't, because it gets out of proportion. So that would make some sense.
Thank you. The report also states that some contracts exclude generic drugs from being purchased at the 340B price. Why would contracts only allow for the purchase of brand name drugs?
And again, it's the same kind of issue that it may put the drug into a negative revenue situation for the covered entity. If the fee associated with that and the cost of the drugs puts it into a negative revenue or savings, then that really sometimes doesn't work. And what we heard from some contract pharmacies, if they find that happens, then they may they will consider it not to be a 340B prescription, but a regular prescription, so it doesn't put the covered entity into a negative revenue or savings situation like that.
Should we go to a system where they can decide which to choose, or is the system as it currently exists the better system from your perspective?
Yeah, I think that will require more study to find out how best to do that, because again, you don't want to create negative incentives related to this. You want to make sure that whatever fee that's being charged is not creating that the patient would come out in a worse situation by participating in the 340B program than not.
Thank you, and I look forward to continuing to work with you. And Mr. Chairman, I yield back 2 minutes, 27 seconds.
The chair rejoices. The chair is prepared to recognize the gentleman from North Carolina if he is ready.
I'll be ready in just a second, Mr. Chairman. Thank you for that. Thank you, Ms. Draper, for
5 minutes.
providing your testimony. In the 8th District of North Carolina, I have 4 major hospital networks. each of which uses the 340B program. I've toured their facilities, and they've shown me ways that they use the 340B program to better serve their patients. I believe this program is vital to our communities, and I believe in its mission, but the program can and should be improved. I applaud Chairman Burgess and Ranking Member Green for holding this hearing to allow us to explore solutions to help preserve and strengthen this program for the next generation. One idea that I've been exploring is elevating the 340B program to an administrator-level program within HRSA. Right now, the 340B program is administered by the Office of Pharmacy Affairs within HRSA, but there's no figurehead for Congress to address its concerns to. A recurring theme I've heard from both covered entities and pharmaceutical manufacturers who've come in to talk to me about changes they'd like to see in the program is that they want to see more transparency and accountability. Further, both in the GAO and Energy and Commerce Oversight and Investigation Subcommittee reports recommended this program be given more authority to conduct oversight and resources to ensure proper implementation. The 340B program is utilized by over 12,000 covered entities, and there are close to 20,000 contract pharmacies. It plays a vital role in our healthcare system. However, it is critically under-resourced to appropriately administer this program. By elevating the 340B program to a Senate-confirmed administrator-level program, I believe we can make this program more accountable to Congress, providing more visibility into the program and improve administration of the program. I believe these are goals that hopefully we can all support. Ms. Draper, do you foresee any issues with elevating the 340B program to a Senate-confirmed administrator-level program within HRSA?
Haven't really thought about that, but I think the more visibility that position has would be helpful.
Great. Well, if you have any further thoughts, I'd love to hear your feedback. I appreciate the work you've put into this, and I think it's benefited this committee.
Great, thank you.
With that, Mr. Chairman, I'll yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from New York. Mr. Collins, 5 minutes for questions.
Thank you, Mr. Chairman. I think, Ms. Draper, you've actually answered a lot of our questions. The GAO report was a very specific audit on the contract pharmacies, and I think we've kind of covered that. So maybe I'll spend a few minutes just stepping back for a second. I think sometimes, to summarize things, everyone in this room agrees 340B is a great program. It's been around 25 years, but in 25 years, a lot has changed. Certainly, the types of drugs and the treatments we have to cure diseases, treat diseases, very significantly different today than 25 years ago, and many of these drugs are extraordinarily expensive as they've gone through billion-dollar trials and the like. And I think all of us have the same concern, that the bad actors are identified and we stop those actions. Certainly you've identified some of the issues with contract pharmacies 1,000 miles away, diversion, getting double discounts and so forth. So I think, as we're going to maybe nuance some things, we should always keep stepping back and saying this program's been there 25 years. It's a good program. The pharmaceutical companies support it. Covered entities need it. The grantees need it, et cetera, et cetera. So it comes back to, there's a saying, there's no free lunch. And as we have seen some bad actors take advantage of a 340B, 50% discounts, and they're providing them to patients who are fully insured. So Blue Cross Blue Shield is paying the full bill. The hospital is taking that money, adding it to their operating income, if you will, to cover expenses, not in some cases, the bad actor, not telling us what they're using it for versus grantees who do, in fact. So I absolutely think the transparency is important here. I think we should all remember, because of what you're saying, I have one of my bills is a 0.1% to 1% user fee for hospitals using the program to get into HRSA. While they may not like it, actually, the fewer bad actors we have, the more confidence we'll have this program will continue. And I think we've all heard HRSA needs the resources. You, I'm assuming, agree with that. So that 0.1% to 1%, which is one of the things we'll be talking about, is to address that need. The other one's patient definition. I have a bill here on patient definition. That's quite controversial, but it says this program was intended for the uninsured, the low income, and we are seeing some folks taking advantage and buying, in many cases, oncology practices where the vast majority of the patients are fully insured. And today those are not 340B entities. They are getting purchased. The next thing you know, all these patients with full insurance, the person who's purchasing it's pocketing that difference. I would call that an abuse. So under the patient definition that I'm pushing, The qualified patient would be a person who's uninsured or low income. If someone has insurance, they would not be covered by 340B. I'm not sure if you have an opinion on that. That's probably one of the most controversial pieces, because clearly if it only applied to the uninsured and the low income, that would certainly today be removing money from hospitals who use the funds for their operating expenses. Do you have an opinion on that patient definition piece being only the uninsured and the low income?
Well, I would just say that the patient definition needs to be clear, and it needs to be clear. I mean, I think that's a major issue with the program overall. There's a lot of ambiguity in the rules and regulations, and it leaves a lot to interpretation. So if that's what Congress intends, then, you know, that should be clear in the program. That should be a clear definition.
Well, and I think that's why, again, Mr. Chairman, this is such a good hearing, because we're covering these things from A to Z to start a dialogue, starting with the fact everyone wants 340B to continue, to serve what it was intended to serve, but we need to know where it's going, and what we can't have are the bad actors taking advantage of loopholes or otherwise to pad their bottom line, when in fact, you know, they should have a responsibility to run their operation, and everyone needs more money, everyone would like more money, but to take it off the backs of pharmaceutical companies inappropriately could lead to higher prices overall. At some point, if people are taking the money out, you're going to see increases, just the opposite of what we want to see today.
And I would say what will go a long way is the intent of the program, clarify that, clarify the rules, and make sure that there's a really strong oversight infrastructure in place. Those will go a long way to improving the integrity of the program.
Which is what all of us want. So thank you for your testimony, and Mr. Chairman, this is a great hearing. Thank you for holding it. I yield back.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentlelady from Indiana, Ms. Brooks. 5 minutes for questions, please.
Thank you, Mr. Chairman, and I apologize, I was in another hearing as well. A May 2018 brief by MacPac highlights the Medicaid exclusion file that HRSA maintains to help prevent duplicate discounts does not apply to the drugs dispensed by contract pharmacies. And while certainly recognize that identifying and preventing duplicate discounts is the legal responsibility of the covered entity, given your research and the complexity of the program, do you think it is likely that a significant percentage of covered entities with contract pharmacies are at risk of violating the law by providing those duplicate discounts? And if you could go into a little bit of detail.
I think there's certainly a risk related to Medicaid managed care. 60% of all Medicaid drug spending is in managed care, and 70% of all Medicaid drug prescriptions are written for Medicaid beneficiaries in managed care. So I think the potential risk is pretty large. We don't know the extent. We haven't looked at it, but we actually will be starting work very soon looking at duplicate discounts in the 340B program.
Is that a separate study you're doing?
Yes, and we're the team that did this work. We will be moving over to that work very soon.
And what, can you talk to us a little bit about the parameters of that work?
We haven't really scoped it yet, but we will be looking at, you know, basically duplicate discounts related to the 340B program, including managed care. So we just staffed it. We actually haven't staffed it yet, but the staff from this job will move over to that job, and we'll begin work very soon.
And do you have any sense of the approximate timing of how long that work might take?
Yeah, it's hard to say, but I would say 9 to 12 months, something like that. It depends on how, you know, we'll have to scope it and see, you know, how broad the scope will be. But we will be happy to, you know, provide that information subsequently.
I think that would be very helpful to this committee. Let me shift with respect to third-party administrators. To your knowledge, does the use of third-party administrators prevent findings of noncompliance, and if so, at what cost to the covered entity?
Well, the role of third-party administrators is to review claims to make sure that patients are 340B eligible. So, you know, it is a risk, I guess, a risk aversion process, and if the TPA doesn't do it, then someone within the covered entity needs to ensure that those patients that are getting the drugs are actually eligible patients. So what we found is that you know, we had a limited number of TPAs, but they charge anywhere from like $3.50 to $10 per prescription, I think is what they told us, or they do it also, they may do it on a per contract basis or per covered entity. like $25,000 for a year.
So if TPAs are paid a flat fee per contract pharmacy, do you believe that incentivizes less oversight and/or increased noncompliance of that contract pharmacy when it is a flat fee?
Yeah, it's hard for me to say. I don't think we really had the evidence to suggest either way.
Okay.
It was really more of a descriptive piece to really get some insights into the financial arrangements.
Okay, thank you. I have no further questions. Yield back.
Gentlelady yields back. Now recognized will be Mr. Carter from Georgia. 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Draper, thank you for being here. This has been very, very informative, and I appreciate the work that you've done. Just full disclosure, before I became a member of Congress, I was a practicing pharmacist, actually participated in some 340B programs. But I'll be quite honest with you, I did not know the extent to what this program was being done until I got to Congress. I thought it was for rural hospitals and for low-income patients to get discounts on medications, and it was only until I got here that I discovered that it was being exploited, if you will, not illegally, but just that it wasn't defined well enough to cause people to not be able to exploit it like they were. I'm not saying that they were doing anything illegal. They were just simply, I'm just simply making the observation. It appears to me that Congress never made it clear exactly what we intended for the program to be. One of the things that's been discussed here today has been the number of contract pharmacies. And I want to make sure I understand, accessibility to these medications is very important. So it appears that the theme has been as if we can cut down on the number of contract pharmacies, we can control the program better. Whereas I would submit that it would be better if we could have a better patient definition and of who is eligible and who is not eligible, and not necessarily to have to cut down on the number of contract pharmacies. Would you agree with that?
I don't think our work suggested cutting down on the number of contract pharmacies. I think it's just suggests having more rigorous oversight and the rules be clear.
Well, and I appreciate that. One of the things that concerns me is that there's legislation being proposed now to codify the current patient definition that dates back all the way to 1996. I mean, we got staff members who weren't even born then. So, that's, to me, ludicrous to even think about doing that. It has to be updated. But as I understand it, GAO and HHS have both identified the unclear patient definition as being one of the major problems. Is that true?
Yes.
And that's one of the problems that HRSA is having with really overseeing the program, is that the patient definition is not clear.
Well, it isn't clear, and that's one of our outstanding recommendations from 2011 that still needs to be implemented.
Right. Well, let me ask you something. Are you aware of a memo from the Congressional Research Services to Senator Cassidy that was dated on June 18th of this year?
Yes, I am.
So is it fair to say that the gist of that memo was to confirm that under the current patient definition that is being proposed to be codified into the system, that it's possible for a 340B hospital near Hollywood to get a discount for Botox to be given to a movie star, and then to get a discount, a 340B discount?
Well, outpatient drugs are covered.
So that, yes, I mean,
yes
or no?
It's possible.
So it's possible for Botox to be under the 340B program, and for a Hollywood star to get a discount, and for that hospital to get a discount out of that drug. The thing is, Mr. Chairman, I don't think there's anyone here who doesn't think that this is a good program. It is a good program, but obviously it needs some safeguards. Obviously, we need guardrails on this program. We need to do some things and change some things to make this program better. If indeed, when the program was established in 1992, as some have suggested, that it was not clear exactly what it was intended for, we need to make that clear in Congress. This is incumbent upon us in Congress to make that clear, and that's what I want us to do. Let me ask you one other thing, and that's about the duplicate payments and the claims modifiers. I understand that some hospitals are getting discounts for both Medicaid and for the 340B program. Would a claims modifier not work to solve that problem?
The guidance isn't clear. There's been no guidance issued around related to Medicaid managed care. That's where the issue is. It's not, so there is, there is a process in place for managed, Medicaid fee-for-service, but there is no process for Medicaid managed care, which is,
Right.
which is where the problem is.
And that's what you said in your report. It says the potential for duplicate discounts related to Medicaid managed care has existed since 2010 when manufacturers are required to pay Medicaid rebates under managed care, and currently there are more Medicaid enrollees, prescriptions, and spending for drugs under managed care than fee-for-service.
Yes, that's correct.
So that just needs to be clarified, right?
Right, there needs
You know,
to be guidance
I mean, the resolution to all this seems to be simple. We just need to update the code.
And I think somebody mentioned this, that, covered entities, I mean, they would like to have the guidance issued so that
Absolutely.
they're clear about what they're supposed to do as well.
Well, I hate to put this on record, but this is one time I kind of feel bad for the agency because we certainly haven't given you any guidance at all. And we need to do something about that. And I want to thank you, Mr. Chairman, for holding this hearing and for us addressing this issue.
Thank you.
I yield back.
I appreciate the gentleman's time has expired. He yields back. The chair now recognizes Ms. Eshu of California, 5 minutes for questions. Ms. Eshu, you're recognized.
Thank you. I was just in deep thought for a couple of seconds there. Thank you, Mr. Chairman, and thank you, Dr. Draper. I hope that you'll be able to enlighten me in the following area. Do you think that the reporting requirements relative to the qualification for how 340B savings are spent differently among the types of hospitals currently eligible to participate in the 340B program, do you think that anything needs to be done relative to reporting requirements?
Right now, there are no reporting requirements, so.
There are what?
There are no reporting requirements around, are you talking about savings or revenues generated from the 340B program?
Well, they all have reporting requirements when they have a 340B program, but I don't believe that the reporting requirements are all the same. Do you think that something needs to change with that?
Well,
or do you think that what's in place is appropriate?
Well, there are no requirements for covered entities to account for how, what savings or revenues they generate from the program.
Do you think that there's an inconsistency in reporting requirements that limit HRSA's ability to effectively oversee and administer the 340B program?
I'm not aware of anything that's inconsistent there.
Does GAO have recommendations regarding what information should be reported by all covered entities?
We have not made recommendations around that issue.
What do you think the major issue is? Let me ask it this way. What do you think is broken, if anything?
I think as I said, I think there's the intent of the program needs to be clarified, that the rules and regulations.
What does that mean, clarified?
So the intent is, it was developed in the early 90s when the program first became operational. There's a lot that's happened in the landscape, healthcare landscape. I think some folks have talked about the increase in the price of drugs, the new technologies in healthcare. I think just the types of entities that are currently serving people. These entities, particularly hospitals, are much more complex organizations than they used to be. So there's so much that has changed, and I'm not sure that the intent of the program has, and also healthcare reform is a big piece. But so it's not clear that the changes in the landscape. Healthcare landscape have really support the current intent of the program. And it's funny because we talk to folks and they think that the intent of the program is to serve low income people. Well, that might be an indirect.
It's not to track individuals. It's for institutions.
Right.
That
It's for covered entities.
The entities that are responsible for taking care of poor people.
Mm-hmm.
But that principle hasn't changed. That's why I'm not so sure what you're specifically recommending.
Well, I think we are recommending that the intent, the oversight, the more rigorous oversight, which will help improve the integrity of the program.
You're saying that Congress should do more oversight?
No, I'm talking about that HRSA should do, you know, should have more rigorous oversight of the program. And
How? I mean, give me something specific. I asked
think
you
we
about
made-
reporting, and that I think that there are different reporting requirements of institutions, but give me a specific.
So we made 7 recommendations in the current report. You know, one was to institute a process for ensuring that duplicate discounts don't happen in Medicaid managed care. So that's a clear prohibition of the program that they don't have guidance for at this point. So I think that's one. I think making sure that they have, you know, another recommendation was that they have clear, that the number of contract pharmacy arrangements is clear, that they you know, track each one of those, because right now they're really understated. So the HRSA understates the number in their database of the number of contract pharmacy arrangements that currently exist. And that's an important piece for oversight, because that information is helpful to inform, you know, which covered entities they select for audits, because it does increase, you know, the complexity level of an entity does factor into their audit selection. So those are a couple issues.
Thank you. Thank you, Mr. Chairman.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Virginia, Mr. Griffith. 5 minutes for questions, please.
Thank you very much, Mr. Chairman. HRSA does not require all covered entities to provide evidence that they have taken corrective action and are in compliance with program requirements prior to closing an audit. Instead, HRSA generally relies on each covered entity to self-attest that all audit findings have been addressed and that the entity came into compliance with the 340B program requirements. Ms. Draper, does HRSA re-audit a covered entity after a corrective action plan is submitted to ensure compliance before they close the audit?
They don't before they close an audit, but they have conducted 21 re-audits over the course of I don't know, a couple of years. So, in the findings of those, one, they found a covered entity, one of the audits where the entity did not implement their corrective action plan, as they said. They found 12 other instances where the non-compliance findings were similar. 3 were for the exact same issue. So, you know, even in the re-audits, they find, you know, that, audits probably should not have been closed.
And so wouldn't it be a better practice if they would at least do a mini audit or something to make sure that the problems were addressed before they just close the audit and say, here are your problems, but we're not coming back to check on you, you know?
Or require some kind of documentation. You know, at GAO, I mean, it's a very similar process. We don't close a recommendation unless we have specific documentation that something has actually been implemented. A lot of times, an agency will submit to us that they have a plan. Well, a plan doesn't do it. It has to be actually implemented. So I think, you know, more rigorous information that they require from the covered entities as to what they've done.
I would agree with that. And I know that some of the hospitals are, you know, saying that they use the, I'm switching gears on you, but they use the monies that they generate or that they get from using the 340B program to help somehow, but I noticed that about half of the covered entities that you all reviewed, the uninsured patient discounts just didn't go to the patient. And I know they may be using it somewhere else, but don't you think that's a little bit of a problem, that we ought to have some way to track that to see that it's at least going to help folks who are low income?
Yeah, so what we found of the 55, so we sent out 55 respondents that responded to our questionnaire. 30 said that they provide discounts at some or all of their contract pharmacies. 25 said they did not, but of those, 4 actually provided discounts at their in-house pharmacies, and then some others talked about that they provide benefits through like their charity care program that may cover
and I get that. I just think that since we're putting this program out, we ought to have some way to track that to make sure, in fact.
Yeah, there are no requirements for discounts, that the program provide discounts.
Right, and I noticed that on page 32 of your report, you all found that some patients are even required to cover the cost of a 340B dispensing fee. So not only are they maybe not getting the benefit, but then they're having to take money out of their pocket to pay
the contract pharmacy a dispensing fee. Should Congress establish a new policy prohibiting that practice?
Well, I think, so what we did find was some of the some of the contract pharmacies said that if a patient is uninsured or low income, that they would discount that fee or just eliminate it altogether. So there was, again, there's a wide range. I mean, it's hard to make generalizations because we saw so much variation in how these arrangements worked and the financial arrangements. So it's just. But
I will tell you, it troubles me when I see that we've put the program together to make it less expensive for folks, and then we find that through the process, in some places, they're actually charging these folks a dispensing fee. That troubles me.
Well, you certainly don't want to discourage people from getting the drugs that they need.
Exactly. Looking at my various questions as my time runs out, do you think that, or what would the effect be of limiting to fair market value the fees a contract pharmacy could charge a covered entity? That is, what if HRSA were to take the profit motive away from contract pharmacies and ensure that the benefits of the program would actually flow to the covered entities and not the contract pharmacies?
Yeah, that's a really difficult question. I think the issue.
I try not to ask all the easy ones.
That you don't want to create negative incentives that the program doesn't work as intended, and I think that so it's hard to make a blanket generalization because I think some of these things really do require further look-see to see what the impact actually is.
All right, and I think that's fair, and I appreciate your time and your testimony here today, and appreciate it, and thank you very much, and I yield back.
Chair, thanks, gentlemen. Gentleman yields back. The chair would observe that as we finish the first panel, we will go immediately into the second panel. So to the members of the second panel, consider this your 5-minute warning that if you need to take a break before we go into the second panel, this might be the time to do it. The chair is now pleased to recognize the gentlelady from Illinois. 5 minutes for questions, please.
Thank you, Mr. Chairman, and I want to thank you so much for being here. 340B is absolutely essential to people in my district. With skyrocketing drug prices, 340B is literally a lifesaver. In my district, Advocate Health has used its 340B savings to provide support for uninsured or underinsured patients through the child vaccination programs and the medication assistance program. 340B is not the driver of high drug prices. The pharmaceutical corporation's unlimited power to set the list price is the driver. The 340B program is one that actually attempts to lower drug prices. There are many things Congress could be doing right now to lower drug prices. For example, a California law went into effect earlier this year that requires drug makers to give advance notice of large price increases. In response to that, Bloomberg reported that in the past 3 weeks, Novartis, Gilead, Roche, and Novo Nordisk sent notices to California's health plans rescinding or reducing previously announced price hikes on at least 10 different drugs. If we really want to get serious about lowering drug prices, a first step would be a bill that I have, H.R. 2439, the Fair Drug Pricing Act. Like the California law, this bill would require basic transparency for drug price spikes. There's been a lot of discussion about greater transparency in the 340B program, and we can strengthen the 340B program by increasing accountability for pharmaceutical corporations that currently have very little oversight. I want to follow up on Representative Matsui's questions because I'm also concerned with the disparity between audits of covered entities and pharmaceutical manufacturers. So, Ms. Draper, you stated that 831 covered entities have been audited, where only 12 pharmaceutical manufacturers have been audited. So I'm wondering, when a pharmaceutical corporation is audited by HRSA, what is being evaluated?
Yeah, so I want to correct, those 813 covered entities.
Oh, I got the numbers changed
I said
around,
it wrong
sorry.
to
Okay,
begin with.
13.
Mix up the two.
Maybe I read it wrong.
So as our understanding, we haven't looked at manufacturer audits, but our understanding is that when HRSA has done 12 to date, they began in 2015 with 1 and then 5 each year thereafter, and I think they're on schedule to do 5 this year. So our understanding is that they look at like the drug pricing, the ceiling, and some other policies and processes. And, it's also our understanding, just based on the information that we found from their website, is that they've had no findings related to the manufacturer audits to date.
Say that last sentence.
That they've had no findings related to the manufacturer audits. So I don't know the extent that we haven't looked at that, so I don't know the extent to which what they've looked at, or the extent, their scope, or methodology.
So in other words, as far as you know, HRSA has not punished or penalized or otherwise fined a pharmaceutical corporation participating in 340B for exceeding the statutory ceiling?
Not based on the audits that I understand. There's still some things that, they have statutory authority to do. They're supposed to do posting the ceiling prices on a website, creating civil monetary penalties, and also a dispute resolution process. Those things have, been delayed. So those are things that are still outstanding for HRSA to implement related to manufacturers. So I don't know when those are projected to be implemented, but they have been, there have been continual delays in getting those implemented.
So would you expect that if they actually did those kinds of inspections, that maybe at least one or two might have exceeded the fact that there's no action?
Yeah, it's hard for me to say because, as I said, we haven't looked at it, but there are 600 manufacturers, so to do, 5 annually, that's about 0.5%. The covered entities is about 1.5% of the audits.
You stated that compliance measures have been required of pharmaceutical manufacturers. What were those compliance measures, and were those in response to an audit?
I'm sorry, what was the question?
That you stated the compliance measures have been required of pharmaceutical manufacturers, and were those in response to some audit?
Well, manufacturers are required not to discriminate based on 340B participation. So, as far as I know, I assume that that's one of the things that HRSA is looking at. They did revise their guidance on that a few years ago based on a recommendation that we made. But I really can't give you details about, what their audits entailed or,
Okay.
So.
Thank you very much. I appreciate it. I yield back.
Chair, thanks, gentlelady. Gentlelady yields back. Seeing that all members of the subcommittee have had a chance to ask a question, is now in order to recognize Mr. Welch of Vermont, a member of the full committee, for 5 minutes for questions.
Thank you very much, Mr. Chairman, for having this hearing. And I've been listening to the questions of my colleagues and have an agreement with a lot. The transparency that Dr. Bouchon mentioned is important. Mr. Griffin, the point you made about the benefit going to the patient actually raises a pretty serious question, because I bet a lot of the hospitals in your district and mine are similar. For those hospitals, this is really not a question of exploitation. For them, it's a question of survival. And there's a tough call to make, because most of these folks who are dependent on that hospital are relatively, really quite low income in my state. These are nonprofit hospitals in every case in my state. And this question of whether the benefit goes directly to the patient, where they're getting significant taxpayer help for the health care, versus the institution, which in Vermont is so critical. So that's a challenge. I just want to say I appreciate your point, but this is about survival. This is about survival for many of our hospitals. And if they weren't in those communities, and we have some like in your communities where that not only provide, those local hospitals not only provide health care, but they're like the center of life in many of our communities. And we've got to make them successful.
And if the gentleman will yield for just a second.
I will.
I would just say to the gentleman that I appreciate that point, and that was not directly where I was going, although I think I needed to ask the question. But I would like for us to be able to see that the benefit, if not going directly to the patient, is going into low-income coverage, as opposed to just speculation that it is.
Well,
Kind of a tracing
I'm willing to work with you on that, but here's the way I see it, and this is why this is important. Any program we have, whatever program it is, we should be monitoring it and making certain that it is doing what it's supposed to do. And it might be something you propose or something I propose. Accountability matters. I believe that. But there's also a larger issue here about the pharma prices that are just killing us. They are enormous, and it is the fastest rising cost of health care, and it is, this program is a small component of what the pharma, the pharma profits are very, very, very substantial. And this program, for whatever issues people are raising, really is like 4% of the discounts overall for pharma, and the prices to these hospitals are really pretty brutal. The one bill that Mr. Harper and I have, and as you know, Mr. Harper has good news, we hope. He's waiting for his first grandchild. Otherwise, he'd be here with us. So let's wish him well. But he and I have the orphan drug bill, and I think I'll ask the witness about this. That orphan designation, talking about things getting a little bit out of control, when it was originally passed by Congress, it was to give a preference for drugs that were used to treat, quote, orphan diseases, rare diseases. But the pharmaceutical companies have managed, through litigation, to have that designation apply even when the drug is being used for a very common disease, and it's resulting in the congressionally conferred benefit going for not for congressionally unintended consequences. Do you have any information about how much the orphan drug bill is being utilized for non-orphan diseases?
I don't, other than to know that a lot of those orphan drugs are used for other indications. That's about the extent of what I know.
Yeah, Mr. Chairman and my colleagues, I would hope that we'd give some opportunity for the Harper-Welch bill to be considered by the committee to address that. Thank you, Mr. Chairman.
That is the purpose of the gentleman yield?
Yes.
That's the purpose of the hearing today.
Yeah, I appreciate that, Mr. Chairman. The other issue, it's more of a statement than anything. I appreciate your work. But these pharmaceutical prices are brutal for everyone. But these small hospitals, 14 of them in Vermont, if they lost the 340B program, it would be the difference between black ink and red ink. It's really that dire. And somehow, some way, Mr. Carter, you know, you've been talking about this too. We've got to address those pharmaceutical costs. So I yield back and thank the chairman for this hearing and allowing me to participate.
Gentleman yields back to chair. Thanks, the gentleman. Gentleman would remind members of the committee that we did have a rather extensive supply chain hearing not too many weeks ago. A lot of these issues received a great deal of discussion. In fact, there are legislative products that are in the works as a consequence of those discussions. Seeing no other members wishing to ask questions, this concludes our first panel. Ms. Draper, thank you very much for your time and your testimony. You've answered a lot of questions this morning. You've given us a lot to think about. We will now not actually recess, but you are excused from the first panel, and we will immediately seat our second panel. And while we're gathering name plates, and I don't mean to hurry things along, but we will have votes on the floor, and out of respect for our panelists, some of whom have traveled a great distance, we want to try to conclude their testimony and questions before we get distracted with votes on the floor. So as the second panel is being seated, each of our witnesses on the second panel will have 5 minutes, provide an opening statement, and once again, questions from members after that. Today, we are very fortunate to have with us Dr. Deborah Pratt, who is the Executive Vice President of Texas Oncology, Dr. Fred Cerise, the President and CEO of Parkland Memorial Hospital, and Dr. Charles Daniels, Pharmacist in Chief and Associate Dean, University of California, San Diego. We appreciate all of you being here today. Dr. Pratt, let's start with you, and you recognize 5 minutes for an opening statement.
Chairman Burgess and Ranking Member Green, thank you for the opportunity to testify today on the opportunities to improve the 340B program and impact it is having on patients with cancer. I'm Dr. Deborah Patt, a practicing community oncologist in the great state of Texas. I serve as a national leader in healthcare policy, clinical informatics, and cancer research within my practice, and in partnership with national organizations like US Oncology, the Community Oncology Alliance, and ASCO. I also volunteer my time and work collaboratively with Seton, my local 340B hospital, and their medical school affiliate. As a clinical professor at the University of Texas Dell Medical School, I co-chair the Access to Care Working Group to serve vulnerable patients in my community. I share in this committee's commitment to improve the 340B program and will illustrate why providing transparency, oversight, and accountability to 340B hospitals will help to ensure that the vulnerable patients that need it can benefit. In recent years, the 340B program has experienced explosive growth, exceeding $19 billion in drug purchases last year. This rapid growth suggests powerful economic incentives are at work, as 340B hospitals and contract pharmacies get substantial economic benefits from participation. In cancer care, we have many oral drugs that cost more than $10,000 a month. Hospital and contract pharmacies may purchase the drug for $5,000, then sell the drug to patients for $10,000. This 50% margin is pure profit for the hospitals without verification that it is helping patients. Furthermore, GAO underscores that 340B contract pharmacies are also big businesses, sometimes with healthy 15 to 20% profit margins. Some 340B hospitals have enjoyed more than $100 million in savings and have used those profits to acquire independent community oncology clinics and increase market share. This arbitrage opportunity on drugs in 340B to buy low and sell high provides a clear incentive to do this. A recent Community Oncology Alliance report indicates that nearly 700 private community oncology clinics have closed or become affiliated with hospital systems in the last decade. When this happens, the cost of care for patients doubles, and it costs Medicare billions. How do we know that this program is used to enhance care for vulnerable patients? This is by far the most important issue that we face today with the 340B program. Parkland Hospital in Dallas is a great example of a hospital that needs and is using the 340B program as it should be. It's almost 50% DISH, far exceeding the requirements, and clearly needing the program. Unfortunately, Parkland is not the typical 340B hospital. As of 2015, there was only a 1% difference in the amount of uncompensated care provided by 340B hospitals compared to non-340B hospitals. A National Academies report noted that nonprofit hospitals are increasingly displaying business characteristics of for-profit hospitals, and many nonprofit hospital executives have 7 or even 8-figure annual salaries. Because there's no mandate to spend profits on vulnerable patients, some hospitals may use these to build towers or enhance executive compensation. Across the country, there are pervasive and deep access to care issues for vulnerable patients that I see every day in clinic, and I want to share with you some of these experiences, because in the end, it's all about patient care. In Longview, Texas, about 2 hours east of Dallas, a 340B hospital declines to provide chemotherapy to or underinsured patients without upfront cash payments. In Austin, there are widespread shortcomings, delays, and detours in care for uninsured patients with cancer who, for some example, are placed on wait lists for months. Last year, I saw a 50-year-old Austin musician who had a clinical stage 3 breast cancer and was refused services at the 340B hospital. She watched it progress in her chest for the next 3 months until she came to us for care. A 34-year-old pregnant woman with stage 4 colon cancer had to start her chemotherapy during pregnancy. We treated her for 5 cycles as a hospital inpatient under emergency care because the 340B hospital took 8 to 10 weeks to get her an appointment. Another 16 patients I'm aware of sat for more than 6 months last year to wait for gynecologic oncology appointments in the 340B hospital. Some had curable advanced cervical cancer and presented to the emergency room while waiting for treatment. In Kentucky, in February, a lung cancer patient was refused treatment at the 340B hospital due to lack of insurance and waited 3 months before seeking treatment elsewhere. In Boulder, a patient with aggressive lymphoma who had Medicare Part A but was waiting on Medicare Part B was referred to the local 340B hospital to receive therapy. They would not see or schedule him until he got Part B, and he died several weeks later without ever being seen. I urge the committee and Congress to support legislation to provide for the integrity and viability of the 340B program so that we can ensure that it's about helping patients, not hospital bottom lines. Without action, the program will continue to grow, Americans fighting cancer will have less access to care, and patients, payers, and taxpayers will pay more. Once again, thank you for the opportunity to address the committee. I'm happy to answer any questions regarding my testimony.
And thank you for your testimony. And Dr. Pat, I apologize. I mispronounced your name as I introduced you. So again, thank you for your testimony today. Dr. Cerise, you recognize 5 minutes for an opening statement, please.
Thank you, Mr. Chair, Chairman Burgess and Ranking Member Green and members of the subcommittee. Thank you for the opportunity to speak to you regarding the importance of the 340B program. I commend your leadership in ensuring the integrity of the program and hope to give your committee meaningful feedback on your policy proposals. My name is Fred Cerise, and I serve as the President and CEO of Parkland Health and Hospital System. I'm a member of the Medicaid and CHIP Payment and Access Commission, Chair of the Teaching Hospitals of Texas, and sit on the board of the Texas Hospital Association. I'm appearing here today on behalf of Parkland Health and Hospital System. My testimony reflects my views as Parkland's CEO. Located in Dallas County, Parkland is one of the largest safety net systems in the country. Our mission is to care for all who reside in Dallas County, regardless of ability to pay. Our system includes an 878-bed acute care hospital with an extensive network of primary care clinics across Dallas County. We also provide health care in the Dallas County Jail. We're the primary teaching hospital for the University of Texas Southwestern Medical Center and are nationally recognized for our Level 1 Trauma Center, Level 3 Neonatal Intensive Care Unit, one of the largest civilian burn units in the nation. We're also proud to claim Chairman Burgess as one of our many excellent physicians who have trained at our facility. Last year, we provided over $879 million in uncompensated care, and 76% of our patients were on Medicaid or uninsured. We had more than 1.2 million outpatient visits and filled 1.6 million outpatient take-home prescriptions and dispensed over 8.6 million inpatient medications. Our pharmacy department includes 1 inpatient, 7 retail, 1 central fill, and 26 Class D clinic pharmacies. We do not have a contract pharmacy, and our pharmacy payer mix is over 62% charity care. Parkland has participated in the 340B drug pricing program since its inception. You've heard a lot of testimony in previous hearings around the unaffordability of drugs. The 340B program is a lifesaver for our patients. We directly use the savings to provide free and low-cost drugs to our patients. I want to share 2 patient examples today that will illustrate the importance of the program. The first patient is a 53-year-old male with diabetes and a kidney transplant. He's under 100% of the federal poverty level and enrolled in our Parkland Financial Assistance Program. He currently takes 9 prescription drugs, and under our Parkland Financial Assistance Program, he pays $5 per drug. So for comparison, for 1 month, the 340B price would be $255. The GPO price was $451, and the total Parkland copay was $45. This is an example where Parkland passes on more savings to a patient than even what the 340B program provides. The next example is a 61-year-old female with rectal cancer, diabetes, a colostomy. She's enrolled in our Parkland Financial Assistance Program and is on 7 drugs. The 1-month cost for the 340B price was $20. The GPO price was $1,544, and her total Parkland copay was $35. So under this example, the patient's copay was more than the 340B price by $15. However, this patient receives her cancer treatment and manages her diabetes at Parkland. Our 340B savings go directly back into our system to help with the cost of care for individuals like this patient. Here are a few additional facts about our program. Last year, the 340B program saved Parkland over $152 million. You can see additional savings information in our written response to the Subcommittee on Oversight and Investigations inquiry last year. We take compliance very seriously. We have 1 manager directly dedicated to overseeing the program and a multidisciplinary team to assist him with ensuring the integrity of our program. We perform quarterly scheduled audits on both inpatient and outpatient areas. We also perform other targeted audits throughout the year. Health systems like Parkland welcome enhanced transparency requirements and stronger oversight from HRSA. Like Congress, we believe this program should benefit from the populations we serve. We think Congress should be proud of the 340B drug pricing program and what it has done to improve the lives of so many Americans. I know that this program has saved our Dallas County taxpayers hundreds of millions of dollars since its inception, and something we all can be proud of. Thank you.
Thank you, Dr. Cerise. We appreciate your testimony. Dr. Daniels, recognized for 5 minutes, please.
Good morning, Chairman Burgess, Chairman Walden, Ranking Member Green, and Ranking Member Pallone. Thank you for this opportunity to share my experience with the 340B drug pricing program. I also want to say hello to Congressman Peters, my own congressman, who serves on this committee, along with Congressman Matsui, who represents the people of our sister institution, UC Davis Health. I've been able to personally share with Congressman Peters and Matsui the value of 340B discount to UC San Diego Health patients. My name is Charles Daniels. I serve as the pharmacist in chief for the University of California, San Diego's Academic Medical Center, referred to as UC San Diego Health. As pharmacist in chief, I oversee the UC San Diego Health's administration and use of the 340B program. UC San Diego Health is a top-ranked public academic medical center serving the people of San Diego and surrounding communities. We offer tertiary and quaternary services, as well as the resources of an NCI-designated comprehensive cancer center. We meet the criteria for being both a Medicare DSH as well as a Medicaid DSH hospital. Currently, nearly 40% of UC San Diego Health patients have Medicaid healthcare coverage, making Medicaid the most common payer for UC San Diego Health patients, followed by Medicare. UC San Diego Health has been a 340B provider since the program's inception. We have a very high DSH adjustment percentage of 34.77%. UC San Diego Health utilizes the 340B drug discount to furnish discounted or free outpatient drugs, as well as to provide necessary medical services. For example, a benefit of the 340B program is being able to provide some patients direct discounts on their drugs. We also provide patients help reconciling their medications and better understanding how to take their prescriptions when they leave the hospital through our Meds to Bed program. UC San Diego Health invests savings we generate from 340B in teams of physicians that make regular trips 100 miles inland to Imperial County to deliver much-needed medical care to some of the country's most underserved populations. UC San Diego Health also runs one of the most successful HIV and AIDS clinics in the country. The Owen Clinic is a contracted provider for the Ryan White HIV/AIDS program and takes a whole-person care approach to treating patients with AIDS or HIV. They offer primary care and comprehensive specialty care services, including addiction counseling and mental health care. A great benefit of the program is the flexibility qualifying providers are afforded to decide how they can best use the discount to serve the unique needs of their underserved populations. Because the 340B drug discount provides critical access points for so many of UC San Diego Health's patients, we've put into effect numerous practices to promote compliance with 340B program rules. These practices are necessary investments to ensure we remain 340B compliant. At UC San Diego Health, we employ dedicated pharmacy staff to conduct internal audits each month. A random sample of 340B transactions from our hospital facilities, child sites, in-house pharmacies, and contract pharmacies is conducted to verify that those prescriptions meet all of the HRSA requirements to be eligible. UC San Diego Health also hires an outside auditor to conduct an annual review of our 340B program compliance. We provide regular continuing education on 340B rule clarifications to our compliance staff, our pharmacy personnel who work directly with patients at the prescription counter. Additionally, we try to be very intentional about the pharmacies with whom we contract. The 340B outpatient drug discount is the lifeblood of so many services that UC San Diego Health provides to underserved patients. Any efforts in rulemaking or legislation to scale back the 340B drug pricing program would be consequential to our patients and the patients of safety net providers across the country. I welcome this opportunity to answer your questions. Thank you very much.
And thank you, Dr. Daniels. We'll move then to the member participation portion, and I'm going to recognize Mr. Barton of Texas first. 5 minutes for questions.
Well, thank you, Mr. Chairman, and I want to thank our panelists for being here, especially the two from Texas. It's good to have y'all both here. I'm going to ask the first question to the gentlelady, Dr. Is it Pat? Is that right? Dr. Pat? If you wanted to subsidize operating costs of hospitals that serve low-income patients, would you set up a system that uses a discount drug payment scheme to do that? If that was your goal, if you were trying to lower the operating cost, would you say the pharmaceutical suppliers of the drugs had to lower their payments so they could, in essence, subsidize the operating cost?
So I'd say in a perfect world where I looked at healthcare funding, that would not be an optimal system. However, I do believe that the 340B program is a really important program to provide services to hospitals that serve a high proportion of underserved patients. In my opinion, given what we have, it would be optimal to make modifications to the current program to allow it to operate in alignment with its original intent, and to try to move away from some of the changes that render the potential for fraud and abuse. That would be beneficial for all parties.
Well, it just seems to me, and I'm one of the few that was here when these programs were set up. If you're trying to help hospitals with their operating costs, you set up a program to subsidize operating costs. This program is set up to, if you meet the minimum requirement for DISH, percentage of your patients, requires the pharmacy, the manufacturers to provide discounts in terms of drugs. The assumption would be those discounts go to the patients. We're trying to lower the out-of-pocket cost to the low-income patients. Now, that doesn't mean we can't subsidize operating cost whatever way the Congress wants, but we've had this discussion about what the intent was. There's no question in my mind the intent was to pass through these lower drug costs to the patients taking the drug. Dr. Cerise, from your testimony, most of the discounts that your hospital receives do go to the patients, but not all. Is that correct?
In terms of the direct dollar for drug costs, I gave two examples where one, the discount was not as high as the actual drug cost. But in that case, that patient is getting, we're a health system, she's getting all of her other services at very low reduced costs in our health system. So I would say in virtually 100% of the cases, whether it's drug costs, most of the times it's fully through drug costs and more, but in those cases like that one example where it's not, they're getting the benefit through other services, seeing the doctor and being in the hospital and those sorts of things.
Well, I have a discussion draft that's committee staff's put out, and a discussion draft requires that to participate in the 340B program, the hospital has to have at least, I think, 18% of its patient load DISH eligible. Your hospital is over 50%. What would be a well, first of all, should we increase the DISH percentage requirement under current law?
So from Parkland's perspective, as you said, we're going to meet that threshold, whether you increase it, a little bit or a lot, because our DISH percentage is almost 50%. And if you asked us, if you were looking at options for the program, and some of the things that have been talked about, moratoriums, decreasing Medicare reimbursement, for us, rather than have something like that goes across the board, it would be preferential to increase that threshold. I'm sure for other hospitals, we're different than other hospitals that are closer to that threshold. They have other concerns, and but for us, it would not impact our ability.
But you do support increasing the dish percentage. The answer should be yes.
Yes, sir. It would not be the reason people are coming to the program is because of high drug costs. And so it would not be the first place I went, but because it is an attempt to increase the drug to allow hospitals to deal with that. However, as you said,
my time's expired.
If the purpose is to restrict it, it's better than restricting across the board with reducing Medicare reimbursement.
I want to ask Dr. Pat one last question. Should 100% of the 340B discount be passed on to the patient?
I think that we should have 100% transparency about where the money is being spent, because shining a light, having sunshine on this situation, I think would facilitate appropriate use of those funds.
Thank you, Mr. Chairman.
Chair, thanks. The gentleman yields back. Chair recognizes the gentleman from Texas, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. 8 years ago, Congress passed the Affordable Care Act to address the HHS Office of Inspector General reports of drug manufacturers overcharging 340B drugs. The ACA directed the HHS to impose civil monetary penalties on manufacturers and to implement a ceiling price website so providers could verify what they were being overcharged. I understand the implementation of these regulations have been delayed 5 times. For our members on the panel from the hospitals and even Texas Oncology, do you have any way of knowing if manufacturers are following the rules and are charging your hospitals the right price? We'll start with you, Dr. Pat.
I'm unaware, sir. I don't know.
You know, okay. Dr. Sharice, coming from Houston, though, we have similar hospitals like Parkland.
So explain to me again, I'm sorry, the specific question?
For hospitals, and do you have any way of knowing that the manufacturers are following the rules and charging your hospitals the right price, no matter what the this program is?
I tell you, I don't know, maybe Chuck, you'd have, as the pharmacist, would have a better answer.
Thank you for the question. At this point in time, we don't have clear access to what the 340B prices are across the board. We can't see what other places are paying, and we don't have access to the information that we have always thought should be available.
Okay. In 2018, Medicare outpatient prospective payment system final rule included a policy to cut Medicare reimbursements for certain 340B drugs by nearly 30% from the average sale price, plus 6% to the average sale price minus 22.5%. CMS estimates this will reduce critical payments to safety net hospitals by $1.6 billion each year. Dr. Sharice or Dr. Daniels or even Dr. Pat, can you both describe the impact this cut would be on your institutions?
Yes, we project a $2.2 million reduction from that action.
Dr. Daniels?
Our estimate at the beginning of the year was $8 million negative impact on the organization. So that's the best number we have right now.
While I don't have direct impact on my organization, I can speak to 3 changes. One, that it does decrease the financial incentive for hospitals to acquire community oncology practices while they still can enjoy roughly 30% margins on drugs. 2, it actually doesn't take away funds from the system because it's a rebalancing. It's not really a cut. Those funds weren't brought back to CMS. They were given to other hospitals that were providing care. And 3, patients saved money because out-of-pocket patient copays diminished substantially.
Okay. The recent GAO report confirms that the contract pharmacies play an essential role in helping uninsured and low-income patients get needed care, including but not limited to prescription drugs. Covered entities are already subjected to a high level of oversight, both internal and through HRSA audits. Even HRSA, which oversees the program, does not agree on all these recommendations, noting that many of them are overly burdensome. However, the GAO notes that HRSA needs to provide additional oversight over contract pharmacies. Dr. Daniels, can you describe how UCSD used its contract pharmacy arrangement to increase access for patients?
Thank you. And so for the group, we have approximately 63 contract pharmacies. They go all the way from the North County, Oceanside, near Camp Pendleton, all the way to the Mexican border, Chula Vista. Those sites were selected by us based on where our patients were and where their prescriptions were being filled. And we tracked that process from our electronic medical record, each prescription that was sent out. We tracked which pharmacy it was sent to, and those became candidates for inclusion in the contract pharmacy program. What I can say is that there are two things that I believe are important that we've taken as very serious. This is an important program to UC San Diego Health. We have no interest in putting the program or ourselves at risk. So we follow audit procedures very carefully and very rigorously. We do audits on a monthly basis that includes a subset of each of the players in the program: hospital, child sites, contract pharmacies, and our own in-house pharmacies. And that information then is provided back. We analyze it at the department level and at the hospital level to make sure that we've done that. I guess I would also want to share with the subcommittee that over the last 3 years, we've reduced from originally 119 contract pharmacies to 109 contract pharmacies to 63. That is our current number. And that was based on our desire to make sure that we had full accountability. I'm sure that you're all aware, but the covered entity is sole holder of the risk. If there's a violation in the program, we have the accountability. And so we have set up our programs, both for selection as well as auditing, around making sure that there are no violations.
Mr. Chairman, if I could just have 1 minute, because our colleague from Texas took a little over time. On June 1st, HRSA...
Charge it to his account.
Oh, to his account? Well, I just wanted to make sure our side had that extra minute. Can I have that extra minute?
You've already used it.
Oh, I didn't. I'm glad the doctor did. But HRSA issued a final rule delaying the implementation of the 34B drug pricing program, ceiling and price penalties until July of 2019. These latest delays and the mandate that these regulations was 8 years ago. If the administration cares about accountability for 340B, perhaps they should start with implementing the delayed regulatory guidance program. And I thank you for your patience.
Does the gentleman yield back?
Yes.
Chair,
I
thanks.
didn't know I had anything to yield back.
Chair, thanks, gentlemen. Chair recognizes the gentleman from Indiana. 5 minutes for your questions, please.
Thanks for the 7 minutes, Mr. Chairman. I appreciate it. Well, first of all, I want to commend all of you for what you do on behalf of patients. I was a healthcare provider before I was in Congress, a cardiovascular surgeon, and I know what it takes every day to be out there helping people. So I commend all of you and the people that work for you for what you do every day. And CMS, as it's been pointed out, has already cut reimbursement. And my fear is if we don't do something with transparency and other changes to the program, it's going to happen again, because it's about the money with the exponential growth. CMS is looking at the outlay of funds, and they'll cut it again. And this time it's going to hit critical access hospitals and others like in rural Indiana that I represent. Dr. Patton, in your testimony, you gave examples of patients at 340B hospitals without insurance being treated differently than those with insurance, which I think is appalling, by the way, as a provider. And in some cases, their cancer treatment is significantly delayed due to their insurance status. This is exactly why we need transparency and reporting to be required in this program. Do you think there should be additional requirements for hospitals to report their patient mix and charity care activities, including at their child sites?
Yes, sir, I do. So I think there are 3 changes that are important in the program. I think that you need transparency, because I think when you shine a light on anything, the sunshine provides better behavior in general.
Agreed.
2, accountability, and 3, definition of a patient. Because of the laxity in definition of a patient, it provides a lot of opportunities in variability of interpretation between qualifying entities, especially with the expansion of the contract pharmacy relationships. So for example, if you have an entity that's maybe seeing 100 new cancer patients per year in a market where they have 50% market share and 19 contract pharmacy relationships, they might capture 50% market share in that community of oral scripts that are written just because of the lax definition of a patient. And that's not really appropriate, because those patients aren't really being managed by a smaller oncology provider. So I think those 3 components are critical.
Thank you. Dr. Cerise, obviously I believe in more transparency, and it sounds like both you and Dr. Daniels, you do it internally. We appreciate that. I've introduced a bill, probably everyone in this room is aware of, the 340B Pause Act, and I also have a discussion draft, both of which address reporting. Does Parkland track, and I know you've already answered this, but just to reiterate it, does Parkland track how 340B savings are spent? And do you have any ideas or recommendations to Congress about what type of additional reporting requirements for the program that might be reported to HRSA or to the Congress so that we can get a handle on this?
We do track our savings, and we know when we're delivering over $800 million in uncompensated care, that savings is gone in to support that. We're fortunate to have Dallas County taxpayer support that lets us do that. But with 8% commercial business, we have limited ability to generate revenue elsewhere, and programs like 340B help us to do that. And so I think looking at payer mix among health systems and seeing what that mix is, including the uninsured, looking at outpatient metrics, the dish formula is an inpatient formula for an outpatient program. So getting an idea of what people are doing on the outpatient elective side of the equation would be important as well, and then tracking programs and what benefit of those programs is to the population that they're taking care of, reporting on that.
Dr. Daniels?
So we have some data. Right now, we currently provide about $155 million in undercompensated care, an additional $17 million in charity care. For that, our current estimated savings from the 340B program is approximately $87 million. UC San Diego and I personally support greater transparency, the idea of sharing what we're not afraid to share and show what we've done. The question will largely be how that transparency is generated, what the numbers might look like, and making sure that they're doable administratively.
Great, because some hospitals, including the largest health system in the state of Indiana, have said that the reporting requirements in the PAWS Act are too burdensome. Sounds like that you all already have internal data that, could we require things that are too burdensome? Sure, that's what government sometimes does. That's why I would appreciate your ongoing input, and anyone that has any ideas about what is practical, doable, but also gives us the information we need so that we prevent further CMS reimbursement cuts, which are going to happen if we don't get a handle on the program. Thank you. I yield back.
Gentleman yields back. Chair thanks the gentleman. Chair recognizes the gentleman from New Jersey, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Daniels, I mentioned in my opening statement that I have always deeply supported the 340B program, and I've always tried to work in a bipartisan fashion to strengthen the program, ensure appropriate and thoughtful reporting and transparency, and give the agency the resources that it needs to oversee 340B. And the program plays a critically important role in our healthcare system. I don't want it to be lost here today that the majority investigation on 340B and the countless hearings we've had in our committee have reaffirmed the point of the value of 340B on both sides of the aisle. And I think it's a good thing that we expanded the types of hospitals that can participate in 340B in the Affordable Care Act, because that means that more dollars are going to stretch medical and social services for those in need. However, I agree that it's very important to make certain those dollars do in fact go towards expanding services as the statute dictates, and that all covered entities are carrying out the 340B program with the people they're intended to serve at the center of any policy decision and in full and transparent compliance with the law. It would seem like an easy concept to track and document the savings to ensure the statute is met, but I know that's actually quite complicated, and I'd like to understand this better given the interest in the issue. So would you explain well, I'll ask Dr. Daniels, can you explain the complexity of tracking savings from 340B discounted drugs, and how does University of California at San Diego ensure these dollars go towards expanding services for vulnerable patients? And then similarly for Dr. Cerise, if you could also answer the same question to hear how Parkland handles this issue. So I guess we'll start with Dr. Daniels.
Thank you. Let me speak to the question of how they're applied. There's no doubt that the complexity of how the discounts are accrued makes it very difficult for us to identify exactly. I think I used the phrase estimated impact, cost savings of about $87 million. The flow of the information on the drug costs comes back, and it's not associated specifically with a given patient. We can track the amount of discount that comes back into us, and I think that's an opportunity for standardization over time. But I think the biggest challenge that I see is being able to separate the payment that comes back to the organization from the payers. From the drug cost side, we can track that, but it's not at the patient-specific level.
All right, and then I'll ask Dr. Cerise the same thing with Parkland.
Same response. We can track that in aggregate, looking at our drug spend, but on an individual patient level, we don't track it that way.
I mean, do you have any suggestions to change that so we could have better tracking?
So all our pharmacies are 340B pharmacies. We don't have mixed inventory, and so our patients that we serve are eligible for those discounts. And so whether it's at our central site or child sites, we will look at the cost of drug, our GPO costs, our 340B costs, and you can calculate the difference there to understand the savings. But what my pharmacists say, you can convert at an individual patient prescription level tracking. Oftentimes you don't know what your reimbursement is at the time the dispense is in anyway. It's very difficult to do it at that level of detail.
All right, well, let me just say, I want to point out that so many of the bills here today focus on huge amounts of reporting, and I think we all need to remember that we have an agency with less than 10 people on staff dedicated to managing 340B, and we need to set up our agencies up for success, and we should give the agency what it needs to effectively oversee the program. So we'll look into that better. But thank you both for your input. I appreciate it. Thank you, Mr. Chairman.
Chair, thanks, gentleman. Gentleman yields back. Chair recognizes the gentleman from Kentucky, Mr. Guthrie, 5 minutes for questions, please.
Thank you. Thank you, Mr. Chairman. Thank you for the opportunity for the panelists to be here. And Dr. Pat, I'll start with you. In your written testimony, you explain how consolidation of private oncology practices might be an unintended and unwelcome byproduct of the 340B program. What guardrails do you think Congress needs to put in place to hinder this? And are there other specialties that we should be aware of where this same trend is happening?
Yes, sir. Thank you for the question. So I think that if you make 3 changes to the program, it will substantially enhance its integrity and change some of the misuses of the program and not promote consolidation. Again, it's transparency, accountability, and definition of a patient. I think that those 3 things will substantially diminish program use in ways that are not beneficial for patient care. Because I think nobody is going to argue with organizations that are using this to enhance the care of patients. It's the lack of clarity in how organizations are using it, whether it's to benefit patients or for other strategic initiatives that remain challenging. So I think those 3 things are important. I do think this isn't just an oncology problem. We've consolidated oncology practices, but actually there are many practices that have similar outpatient drug utilization characteristics, rheumatology, ophthalmology, gastroenterology, neurology, that are all subject to the same issues. I think actually the most consolidation in the last few years has been in ophthalmology practices, as there is a tremendous benefit of doing that. And I would say comparably, for our physicians in the room, there are other medical subspecialties that have also consolidated based on similar issues. So if you look historically at cardiology, where the rates, there's a site of service difference in rates of reimbursement for echocardiography, you've seen cardiology practices all align with hospital systems. So I think that it is subject to more consolidation of other medical subspecialties. And if we make the program more transparent, accountable, and define a patient in a more meaningful way, that those are things that we can do to make sure that the program is used to care for vulnerable patients.
Thank you. Thank you for your answer. And then Dr. Daniels, I noticed in your testimony that you mentioned that UC San Diego does pass on 340B discounts to low income, but on a case-by-case basis. How do you determine which case-by-case, and should there be a standard that?
Well, there is a standard, so the testimony.
Apply the standard on a case-by-case basis?
The testimony may have misrepresented.
This is not inconsistent, you're right.
We have an algorithm. Patients that come to the counter, we have information on their payer. For those patients that come with either a low family income, we use an algorithm where the pharmacist or the technician at the counter asks those patients what their annual income is. It's an honor system, we don't check it. And depending on their percentage of the federal poverty level, we have an algorithm that either gives the whole package to them free, a separate category of, I think it's 350% of the federal poverty level to 400%. They get a different discount, but the drug gets free, and they do the copay. And then for those patients that have a high copay and have a low family income, then they also get the drugs for that discount. So,
Okay.
So it's not random, I guess I would say. And the procedure has been fully vetted by our compliance office to make sure that we're doing the right thing.
Good, that makes sense. Also to you, and then Dr. Charisse, you both mentioned in your written testimony performing self or internal audits to ensure compliance with the 340B program. Can you, about 20 seconds, what kind of audits you guys do? How you go about it? Or do you just want to do it, Dr. Charisse, go? I guess one of you answer. And one shake your head whether you agree or disagree.
Yeah, because I won't get to the details. We have a 340B pharmacist who's dedicated to this program. So he will look at all of our sites, our child sites, and look for things like patient definition for duplicate discounts. Are we complying with Texas Medicaid law, acknowledging on the scripts that they're a Medicaid patient, that sort of thing.
Okay. Similar, Dr. Daniels?
So we have, and in the package, in fact, it was on the screen a little while ago during my opening, we do have an algorithm, or I should say a flow chart, that is used by each of the pharmacies to decide whether or not they meet the criteria. But as far as the audits are concerned, let me just briefly comment that the audits that we look at are comprehensive. They go to all the areas of the program. They look at the patient eligibility. They look at the location where the service was provided to make sure that it is part of our rules, our HRSA rules. And as a result of that, we get reports. They come first to our pharmacy leadership team on a quarterly basis. And then at the end of at least twice a year, then our 340B Executive Steering Committee meets, and their job, that's a multidisciplinary group, and their job is to review it. And
Gentlemen's time has expired, and I'm just hurrying us along because we will have votes on the floor, and I'd like to, for your benefit, to conclude this panel before we leave. Gentlelady from California, Ms. Matsui, is recognized for 5 minutes, please.
Thank you, Mr. Chairman. Thank you very much for joining us today. As you know, that UC Davis Medical Center is in my district, but I consider all the UC systems an important constituent, and thank you for representing UC Health as a whole today. Your testimony specifically touches on the original intent of the 340B program, and I think that is really very important. The program was never designed to be a drug discount program for patients, rather a discount for the providers to ensure they're able to best serve the vulnerable and low-income patient population. And particularly in California, which has been successful in implementing the ACA and extending health care coverage to most of the population, the need to support community providers remains, despite the intentional reduction in charity care across the state. And that's why my legislation, H.R. 6071, codifies the intent of the program in order to eliminate confusion. Dr. Daniels, what does a hospital like yours have to do to be eligible for the program?
So we are one of the original DISH hospitals, going back to the 1990s legislation. In order to meet that target, we come in at a DISH discount percent or adjustment percent of 34.77, I think it is, substantially above the minimum cutoff, and that gives us, I guess, qualification as a DISH hospital, and that's how we participate.
Okay, your testimony touches on the various practices UC San Diego Health has in place to promote compliance for the program. Can you describe some of those practices?
The compliance is very important to us. This is a really important program for UC San Diego Health, and so we've taken that seriously. And in fact, as we've gone through our compliance, we've done two things specifically to help us assure compliance. We follow the HRSA rules all the way through, from patient eligibility and how they're qualified. We follow the process of making sure that we can verify and account for all of the steps in the program. The audits include such things as looking at the patient prescription itself, making sure that all of the pieces are in place, that it's an eligible provider that is part of our contract or paid medical staff. And in the process of doing that, we also look at where the encounter was for that patient. Right. So those are all elements of our regular audits of all of our...
And it seems to be very complete, and I think there's a lot of transparency there already. Dr. Daniels, you indicated that you calculated approximate savings about $87 million from this program. Is that correct?
That's the best estimate we have right now.
And the best estimate, and I understand that HRSA is supposed to implement a ceiling price website, and which should have been done years ago with the ACA, and apparently it's stuck somewhere in OMB. So there's a lack of transparency on the fact of the drug manufacturers as far as the ceiling price. And I imagine that makes it difficult for you to calculate some of the savings yourself, right?
It totally is. We don't really know what the actual price is supposed to be, so we have to make estimates in order to identify the difference between the price that we're paying under 340B and what the next best price would be. So the next best price is for the record, the 340B price is not always available to us.
So I think we should have more transparency on the other side, too.
I would agree.
Your testimony provides a brief summary of how savings can be used. Can you talk further about what would happen if you lost 340B savings?
So that is an important question, and I've actually had that conversation more than once with our CEO to talk about sort of how this might happen, because we go through the process on a regular basis of figuring out sort of what that might mean. A fair amount of the funds of the Owen Clinic, which is our HIV/AIDS program that I described earlier, come from not from payer reimbursement, but come from decisions within the organization. It would probably impact our ability to extend our care into the Imperial County, out to El Centro and the areas out there. It would also impact negatively our ability to provide the free drugs to patients that are part of our program.
Okay. All right. Thank you very much, and I yield back.
Thanks, the gentlelady. The chair recognizes the gentleman from New York, Mr. Collins, 5 minutes.
Thank you, Mr. Chair, and thank our witnesses and also Mr. Hudson for letting me jump in. I've got a Boy Scout event I've got to go to in just a second. One of my two bills here is a small one, but as Mr. Green pointed out about the resources of HRSA, it's a user fee of 1/10 of 1% for hospitals using the program. So for every $1 million of drug, you'd have to pay $1,000. So Dr. Platt, would you agree that HRSA needs more resources? And I hope you might agree that my 1/10 of 1% is not onerous.
So obviously I don't represent a hospital that would pay these fees, but in my opinion, having 22 people employed by HRSA to conduct audits of 1.6% of 19,000 qualifying entities is inadequate. And there needs to be some mechanism to staff HRSA appropriately, to resource HRSA appropriately, to empower HRSA appropriately, to make sure that the program can be maintained with integrity.
And certainly I'd point out too, like all of our fees, like PDUFA and so forth, it's not unusual to have other folks pay money into something for, in some cases, a service, in the case of PDUFA and some of the other drug programs. So would either of our other two witnesses very quickly want to comment on that?
Yeah, sure. Well, we think compliance is a big deal. We want to understand the expectations. We want to comply with the expectations. We support oversight and transparency and reporting. And if you're gonna do a fee based on your amount, we have a big amount because we are a large safety net system and we have a very high DISH percentage. So you might look at scaling it according to your DISH percentage.
Something to be considered, sure.
The idea of appropriately staffing HRSA to do its job, I think, is clearly important, and I support that. I think UC San Diego would. My only concern when I hear the statement user fees is whether or not that is likely to take away from the important mission that the 340B program conducts or supports. And so from that point, it's the idea of losing those monies for fees puts a little shiver.
That's why we did 1/10 of 1%, so put it $1,000 per million. Dr. Platt, or Pat, the other issue that I'm covering is the patient definition. That's my bill, and I know it's very controversial right now, but if you look at some of the oncology practices, and some of them I think would have the appearance of being acquired because of 340B, because nothing else changed. The doctors didn't change, the locations didn't change. A lot of times they are serving primarily an insured population base, and the minute they get scooped up by a DISH hospital, then the discounts, they're called in a qualified patient. So, my bill, I know it's controversial, would say that a fully insured patient would no longer qualify for the discount. You have any comment on that?
I would say that I think that tying discounts to the patient is important. And I think that definition of a patient is critical because of the laxity of definition of a patient today. I think that many qualifying entities are receiving discounts for patients that they don't actually manage because I'll just say most cancer patients, they're admitted to the hospital. And so if I see Mrs. Jones who has a lung cancer, I refer her for an outpatient biopsy, but I'm treating her in my private practice. She has a hospital medical record. I have privileges at the hospital. It would be really easy for a post hoc reconciliation vendor to say, hey, Mrs. Jones is a hospital patient. So I think defining a patient is really critical. I would say that I think it would be a big stretch to say that it should only apply for low-income patients, only because then how would hospitals that are seeing such a high percentage of disproportionate share make money to extend other services to low-income patients? So I do think that would be a challenge, but I do think that when we look at patients and qualifying patients, we really need to not just look at the inpatient DISH metric, but because it's antiquated. It's 1992, post-Cold War. We really need to think about outpatients and the outpatients that we're serving, and that would be a more meaningful way to make sure that this program, in my opinion, is in alignment with its original intent.
Well, thank you for those comments, and Mr. Chair, I yield back.
Chair, thanks. The gentleman yields back. Chair recognizes the gentleman from Oregon, Dr. Schrader. 5 minutes for questions, please.
Thank you, Mr. Chairman. Dr. Pat, just trying to get clarity here. You indicated in your opening remarks that the hospital group you worked with, Seton, could charge $10,000 for a cancer drug, and with the discount only be on the hook for $5,000, and they would pocket all that money. Is that reflection of what happens at your hospital group?
So no, I was establishing in my introduction that I round at Seton Hospital. I made rounds there every day. I work with them collaboratively in dealing with poor and underserved patients.
So this didn't actually happen?
Like most community providers, I work in collaboration with our hospital system.
But I mean, I have limited time, I apologize. But did this actually happen at your hospital?
So I'd say I don't know a specific example, but typically hospitals, when they purchase $10,000 oncology drugs, get a 50% discount.
And they pocket that money for salaries and all that sort of thing?
No, what I'm saying, it's a problem of lack of transparency. We don't know how they're using those funds.
Well, I would suggest that that's the reason we have the audits. We heard earlier testimony from Ms. Napier that, they have these audits, they're not doing enough of them. We've heard good bipartisan testimony, we could have more complete audits. But I worry we don't want to give the impression to folks out there that the hospital groups just pocket this money for their own personal gain. The real world is, under the statute and under the audits, they are required to provide services for patients, either wraparound services or direct drug discounts to those particular patients that are Medicaid eligible. So I just want to make sure there's clarity out there. The other thing that, if I may reclaim my own time, the other thing that I'm concerned about in some of the legislation...
Will the gentleman yield?
No. The other thing I'm concerned about right now is the charity care nexus. Under the Affordable Care Act, and actually hopefully through this particular program, the goal is to reduce the amount of charity care that's out there. So if we base a 340B program on just those clinics and those hospitals, those outpatient service or providers that have a high charity care load, we're missing the point. We're actually penalizing hospital groups, coordinated care organizations in my state that have actually reduced the cost of health care overall, provide those wraparound services, and have reduced charity care. With all due respect to my colleagues across the aisle, frankly, they've increased charity care costs recently by undermining the cost-sharing program, by not allowing reinsurance programs, taking away the mandate. If there's an increase in charity care costs, that's not a fault of the system and all the good work that your hospital groups are doing. That's frankly on us here in the United States Congress. So I have problems with the charity care case. Dr. Daniels, when we figure out charity care, do those wraparound services that a lot of our great groups in this country have provided, does that factor into what constitutes charity care so we can compare apples with apples?
Well, in California, because of the Medicaid expansion, we have minimal charity care. We have a fair amount of undercompensated care as a result of Medi-Cal and, to a different degree, Medicare payment systems. So, but there is no doubt the answer to your question is that we include all of those sort of wraparound process as part of what we count in the undercompensated care. So.
Yeah, and I think that's an appropriate thing we have to focus on here. The goal is to reduce charity care. Some folks did not choose to do the Medicaid expansion. Okay, you're going to have high charity care caseloads. But those groups, those parts of the country that went that route, they're actually hopefully enjoying the benefits of the fact that they've been able to use these products. Their 340B program is for these wraparound services to provide good patient care. And I think that's something that we ought to focus on in a lot of the discussion here. Dr. Daniels, furthermore, there's a big audit regimen that already goes on 340B. Apparently it's not perfect. There are some improvements. GAO indicates some. HRSA agrees with some of those recommendations. Some of our colleagues here have some great ideas. Now, what do you think of the current regimen? And should there be some pieces that you might recommend that we should not be doing, and other perhaps audit processes that we should be going through?
What I would say to that is that, speaking on behalf of UC San Diego Health, we've taken the program very seriously. We want to make sure that we're in full compliance. Changes, I think, are potentially in order. We strongly support more transparency, but it should be the right transparency, putting the light not only on the providers, but also the manufacturers, and making sure that the information that we collect as part of that transparency serves an important purpose for understanding the direction the program is going.
Thank you. And I yield back, Mr. Chairman.
Sure. Thanks, the gentleman. Chair recognizes the gentleman from North Carolina, Mr. Hudson. 5 minutes for questions, please.
Thank you, Chairman, and thank you to the panel for your written testimony and the time you've given us here today. It's very important. I mentioned earlier when I was questioning Ms. Draper from GAO that I have 4 major hospital networks in my district. Each one uses the 340B program. They've demonstrated to me how the different ways that the program enables them to better serve their patients. I believe this program is vital for our communities, and I believe in its mission, but the program can and should be improved. One idea that I've been exploring is elevating the 340B program to an administrator level program within HRSA. By elevating the 340B program to a Senate confirmed administrator level program, I believe we will make the program more accountable to Congress, provide more visibility into the program, and improve administration of the program. I believe these are goals that we all could support. I would just ask the panel, each one of you to answer, do you foresee any issues with this legislation? And Dr. Pat, if you'd start with you.
I think there are many different ways you could improve upon administration of the program. I can't speak to which one would be best.
And it's a critical program for us and for our patients, and so anything that can then support the program and to make it viable and continue to work for us and for our patients, we would be in favor of.
So I concur. It's an important program and worth making sure that it is done correctly. I'm not in a position to be able to answer the question of whether or not an administrator level is the right direction, but I clearly support making it, organizing it so that it can be successful and help us be successful.
Well, I appreciate your answers, and I know I sprung this on you. So if I really would be interested in your feedback of your organizations. This is an idea that has some bipartisan support here, and I think we'll continue to pursue. If you have thoughts, if you'd like to submit them in writing, I'd welcome that. Thank you. And with that, Mr. Chairman, I'll yield.
Can you gentlemen yield for a few minutes?
I'll yield the balance of my time.
Yep. I mean, the point I was trying to make with my colleague was not allowing the witness to answer the question is that the implication that we're assuming that everyone are bad actors out there is just factually not true. The issue is we don't know. That's the issue. The issue is not accusing anyone of anything. The issue is we just don't know. And it's unfortunate that that impression was created and then not allow the witness to answer the question. I yield back to Mr. Hudson.
Unless there's anyone else, Mr. Chairman, I'm happy to.
Yeah, yield to me for just a moment, if you would, and then the other aspect of what was brought up, and unfortunately the gentleman's already left, but I would just point out this committee provided 10-year authorization for children's health insurance this year. This committee provided 2 years of authorization for community health centers. This committee provided reauthorization for teaching health centers. True enough, cost-sharing reductions were not considered, not because this committee would not consider them, but because Senate Democrats killed that bill over in the Senate Health Committee. So fair's fair. We can point out some things, but this committee has, I think, an exemplary body of work to point to in the last 18 months in work that we've done to provide affordable care for people who need it. With that, I'm going to recognize the gentleman from California. Or do you yield back, Mr. Hudson? I apologize. Recognize the gentleman from California for 5 minutes.
Thank you. Thank you very much, Mr. Chairman, Ranking Member. Appreciate the panelists coming forward and helping to educate us about what's going on in the real world when it comes to this very important program that we all of our communities depend on. One of the first things, top lines I'd like to remind everybody is this 340B program, is it having a positive effect on rural healthcare in rural America? Just top line, is it?
Yes.
Anybody disagree with that? Everybody consistent with that? Okay, good. I just wanted to point that out because I represent Los Angeles, second largest city in the country. But I think it's important and incumbent upon all of us to always recognize that when something on balance is actually helping American citizens in our district or outside our district, people whose accents might be very different than the people that we represent in our district or what have you, I think it's important that we try to do our best to be good stewards and oversight and making laws to make sure that we try to figure out how do we keep something that on balance is doing good things, how do we keep it going and help to make it better? One of the things that I'd like to ask, again, top line question is, are any state or federal dollars involved in the 340B program? Obviously out in the field. HRSA is federally funded, et cetera, but I mean, out there in the field.
Our oversight is a mixture of local, state, federal funds. So in terms of compliance and oversight, but in terms of, acquiring and how we acquired drugs, but
pretty minimal out there.
Yeah, this is
the application.
This is a drug discount program. It's not federal dollars, right?
Yeah, I guess I would concur that the point of the 340B program has been for 25 years that it doesn't cost the citizens of the United States directly.
That point being made, the intent, and it looks like the intent is following through. Because I've been a lawmaker for 20-some years, and I've actually passed some laws that I had to correct. 'Cause, oops, the intent was. So your point is, 25 years ago, the intent was, and when it comes to public dollars being utilized, by and large, it's following through with that intent, right, in the real world. Yes.
I would say that if you look initially, that's absolutely true. But if you look at some of the secondary consequences of consolidation, which have caused site of service shifts to sites of care that cost double, that costs patients more, it costs taxpayers more, health insurance premiums rise, we pay more in the Medicare system, and so there are secondary consequences that do cost all of us more.
Okay, but not having the 340B program in and of itself would be disastrous compared to the environment that you just described.
I do think not having the 340B program would be disastrous. I completely agree with that.
So basically, Dr. Pratt, you basically pointed out, and thank you for doing that it's not perfect, and there are some inadvertent consequences, but in my personal opinion, those inadvertent consequences, we should always close them as well as we can.
Right.
By and large, the 340B program is a success, by and large, with its intent and its actual utilization in the field.
I think there definitely are successes in the 340B program, but I think to
Overall,
understand that better, we need better transparency.
Yes, and transparency is something that I think we all need more of, and one of the things that HRSA has not grown to the degree to have the proper oversight in the program since the program's inception. My understanding when it started, it was the participants were in the hundreds of facilities. Now it's in the over 10,000, correct? It's some magnitude thereof. And HRSA has been a problem keeping up with that. And I think it's incumbent upon Congress and policymakers to make sure that we try to figure out how do we make that happen? How do we make sure that HRSA actually can keep up so that that transparency is in fact real-time transparency? Because all of the participants are required to report, and apparently they do, but at the same time, when reports are stacking up and those who are supposed to be looking at those reports and verifying them are behind, therein lies the problem. Again, to me, that's I think Congress has more to do with trying to close that issue more than anybody else in the system. Boy, does time go by fast. So my question for Dr. Daniels, can you tell us very briefly and quickly about the reporting at your hospital? Is the reporting for 340B, is that quite involved with your organization? Is it kind of a sort of a full-time effort, or is it just tertiary?
We currently have 2 full-time equivalent staff members that focus exclusively on that, and then there are other administrative pharmacy support that are involved also.
Okay, thank you very much. My time has expired. I yield back.
Gentleman yields back. Chair recognizes the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate my colleague mentioning that we have to look out for folks who might have different accents. I thought maybe he was talking about me. Yeah, he says yeah, and others. But I do appreciate that because this is a good program, and I think we all acknowledge that. But Dr. Pat, I agree completely, and that was the dialogue I was having with my colleague from Vermont earlier, that we need more transparency. We need to see where these savings are going so that we can make sure that this money and the intent is going to where we intended it to go. It may not go directly to patient A, but it ought to be going to patients in a similar circumstances as patient A who's entitled to a benefit. So I appreciate your comments on transparency. We'll see what we can do to make that happen. Dr. Daniels, I noticed in your answer on, what is it costing the taxpayers? You said it doesn't cost the taxpayers directly, which I agree with. I think that's, or close to agree with. But let me see if I can clarify for my own edification and education. So if you're receiving Medicaid, Medicare, which is taxpayer benefit, and the hospital receives a discount for the drug, don't they still bill Medicaid, Medicare? And I'm not saying it's wrong, I'm just asking to get educated. Don't they still bill Medicaid, Medicare for the full cost of that drug?
We certainly bill according to the contract that we have.
And that would be the way the 340B works, though, isn't it?
Yeah, I think we follow the rules.
And I'm not being critical of that. I'm just trying to make sure that, so that would be a little bit of direct money, and then the indirect and the costs may be shifted elsewhere. But I appreciate that. My understanding, and correct me if I'm wrong, and I'm looking mostly at our hospital folks, not Dr. Pat in this one, is that the child sites, those sites where a company has come in and purchased a practice, the child sites are actually growing faster for 340B in the last several years than have been the parent sites. Is that not correct?
That's correct. We have, I think, 83 child sites. And the way our child sites work is anything we have off campus, so we may have one building with 5 different clinics on a floor, that's 5 cost centers and 5 child sites. So as we, like we're dealing with now, we have a behavioral health problem and we're trying to add some services and an extended observation unit, that'll be a child site so we can get access to drugs to treat those patients.
But that's industry-wide as well, isn't it?
I can't speak for the rest of the world, sorry.
How about you, Dr. Daniels?
Yeah, just affirming that statement. If we have in the same physical space, if on Monday we have cardiology and on Tuesday we have endocrinology and on Wednesday yet another clinic, each of those would be registered as separate child sites. So we follow the HRSA rules, and that part of the large number of child sites is related to the fact that that's the requirement in order for us to be able to meet the HRSA rules.
Yeah, and I think one of the concerns, we had I don't believe it was this subcommittee, I believe it was one of my other subcommittees, we had a hearing previously on this same subject area, and one of the concerns raised in that was a lot of hospitals were buying oncology sites in order to bootstrap or beef up their 340B capabilities. Dr. Pat, can you speak to that?
I can. You've seen almost 700 community oncology practices close or align with hospital systems in the last decade, shifting the cost of the site of service. And so let's say you have a hospital and 2 community oncology practices that are 30 to 35 miles away in a suburban area. If those qualify as child sites where it's, the payer mix is predominantly private and Medicare, it allows them a tremendous economic advantage. And so because they have such, an arbitrage opportunity with purchasing power, it's really easy to say, hey, community oncologist A, practice A and B, you can either align with us in the hospital system and let us purchase you, or we're going to open something right next door, and I can see half the patients because I can bleed for years because I have 340B discounts. I buy drugs at half the price, and we're going to push you out of the market. And so that's happened to almost 700 community oncology practices. And so, it certainly alters market dynamics. And while I would say it's not great for community oncology and not great for some rural sites that have closed, but more so shifts the site of service to a more expensive cost of care. And so, we'd love to see some of that economic incentive be diminished over time. And I think that happens when you provide transparency, accountability, and appropriate patient identification, because then that you can show sunshine on the behavior that qualifying entities have, and then make sure that it's alignment and value add to underserved patients. And so I think that those are things that are in the best interest of healthcare in general.
I appreciate that. I see my time is up, and I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Gentleman yields back. Chair recognizes the gentleman from Illinois. 5 minutes for questions, please.
Thank you, Mr. Chairman, and thank you all for your testimony. As Dr. Pat rightly pointed out in her written testimony, that patients without access to health care have a higher, almost a 50% higher mortality rate. This is particularly true for those who can't afford the drug costs to treat their cancer. In fact, not only are cancer patients 2.5 times as likely to declare bankruptcy as healthy people, but those patients who go bankrupt are 80% more likely to die from the disease than other cancer patients, according to studies from the Fred Hutchinson Cancer Center in Seattle. The average cost of cancer treatment runs about $150,000 range. New cancer treatments emerge routinely, but with new hope comes even more cost. 11 of the 12 cancer drugs approved by the FDA in 2012 were priced at more than $100,000 a year. So this is good business for pharmaceutical manufacturers. They have a lot of money and influence, and they use it to attack programs that are aimed at lowering drug prices, like the 340B program. So, Dr. Pat, your testimony notes that many nonprofit hospital executives have 7- or 8-figure annual salaries. You also imply that such executive compensation is enhanced under the 340B program. Texas Oncology is a member of the U.S. Oncology Network, which is a division of McKesson Corporation. Is that correct?
No, ma'am. Texas Oncology is a private practice. We have a business relationship with the U.S. Oncology Network. They provide us electronic health record management services, singularity and group purchasing. And so it is an affiliation, but I work for a private practice in the state of Texas.
Okay, well, just to note that, while you criticize nonprofit executives for their salaries, Forbes magazine recently published an article titled 10 Highest Paid CEOs, and the CEO of McKesson came in as number 1 on the list with an annual salary of $131.2 million. Now, you mentioned that you collaborate, you have collaborative relationships with 340B hospitals, but I'm trying to understand the nature of that collaboration. We know that many of the uninsured patients that at your center that they have been directed to Seton and other 340B hospitals in your service area. Is that right?
So my collaborative relationship with Seton is extensive. For a decade, I ran their breast cancer services for the network. I chaired the breast cancer subcommittee. I still chair under the Division of Women's Health, which is a collaboration between UT Dell Medical School and Seton.
But isn't it also true that you have referred people to Seton and to the 340B program?
So I have referred people to the Seton outpatient clinic. It's called the Shivers Infusion Center, yes. And I round at Seton. So I rounded at Seton every day last week, except for July 4th. I had off. About a third of my patients that I saw were uninsured.
So it isn't clear to me why your center is not treating those uninsured patients right there. Is your center itself a safety net provider?
It's not a safety net provider. So we do provide care for Medicaid and uninsured patients. That's a little less than 10% overall of the percentage of payer mix that we have. across the state. It varies because our sites in McAllen and El Paso have a higher percentage of Medicaid and uninsured. But we don't receive funds from the intergovernmental transfer. We don't have 1115 waiver disrupt funds. We don't have 340B discounts. Being a private practice, we're a PA. So being a private practice, we don't have incremental funds to see and treat those patients. Now, sometimes we do, of course, and we've been very fortunate to get some drugs donated for patients because, as you mentioned, some cancer drugs are very expensive. Actually, we've had a lot of success, so we've taken...
In your experience, have you seen the abuse of 340B in those hospitals with which you collaborate?
I don't know, because I don't know how they use the 340B program. I find it challenging because in my own practice, again, last week when I saw 5 uninsured patients each day, it's a challenge to get those patients into the 340B institution. And more so, being an oncologist, I know that actually those expensive drugs are some of the least important ways to cure cancer. Screening for colorectal cancer and breast cancer and good primary care are some of the best things you can do to prevent cancer mortality. And those programs for uninsured patients in my community are virtually absent. And so that's a challenge that we have. And we work together with the 340B hospital on many efforts to try to improve upon them. And I've dedicated a lot of my volunteer time to those efforts.
Well, it seems that your institution also relies on those 340B hospitals. I'm happy that you said originally that you think it's an important program because...
I do.
I do too, and I yield back. Oh, wait, I do have more time.
No, your time is...
Oh, it's way over. Okay, I
You're
yield
in
back.
arrears. We're going to the next hearing. So I recognize the gentleman from Georgia. 5 minutes for questions, please.
Thank you, Mr. Chairman, and thank all of you for being here. Dr. Cerise, I want to start with you. As you know, HRSA uses a hospital's dish adjustment as dish adjustment percentage as one of the measures for eligibility for the 340B. And under current law, the hospitals must report the state of their low-income utilization rate in the inpatient setting and not in the outpatient setting. And, of course, this can make a big difference. Simply put, the sum of the low-income utilization rate is an inpatient metric that is being used for an outpatient program. Can you tell me in your hospital what's been your dish percentage for the last few years? You have any idea?
About 47%.
47% in the inpatient. Do you have outpatient facilities as well?
We do.
If you were to include those, do you have any idea what it might be at that point?
Yes. I can tell you approximately.
I understand. I won't hold you to
our Medicaid and uninsured percentages would go up if you included the outpatient.
The outpatient clinics?
Correct.
Okay. Dr. Daniels, what about you? Do you have any idea what your percentage is in the inpatient setting now?
The inpatient setting, we're at 34.77%.
If you were to include the outpatient, any idea?
I don't have that information. I know that we also do provide a high level of care in the ambulatory to Medi-Cal patients, and so.
Right.
But I don't know what the number.
Do you have child sites as well? Children's Hospital?
Yeah, we.
What's the patient mix there?
I don't have that information. We don't collect it that way, sir.
Okay, Dr. Cerise, do you?
In general, our child, we don't have children's. Actually, we do see a little bit of pediatrics in our primary care clinics, but most of our child sites are serving adults, and the mix there is going to be roughly 75% Medicaid and uninsured.
So it's higher than in the inpatient setting in the hospital?
Sicker patients in the hospital, we tend to be able to get some coverage for sometimes better than the chronic patients we're seeing in the outpatient clinics, a higher percentage of uninsured.
Well, and I've got legislation that I'm introducing that would require would require the outpatient to be factored in as well, because I think that's very important. Because obviously, one of the abuses, it's not illegal. It's just one of what we consider to be some of us consider to be the abuses, is that a lot of the hospitals are using this in outpatient clinics and outpatient settings when it was intended to be used and based on the inpatient. So, Dr. Pat, if I could go to you, you talked about some of your experiences. They were really frightening to hear of some of the patients who are having to wait and are being denied care. And I was just wondering, what can you suggest that we can do so that this doesn't happen? So that some of these examples, what can we do legislatively in Congress?
So again, in my opinion, reform focuses around 3 issues: having transparency, accountability, and definition of a patient. So I think if you have transparency in how hospitals spend these funds, it helps to solve some of these problems immediately. And accountability, I think, rests in not just having this being a percentage dish metric for inpatients, but have some accountability for outpatients. Because this is really an outpatient program that's measured by dish inpatient. And again, if you look, as 340B programs have grown tremendously, 340B versus non-340B entities, on average, have only a 1% difference in uncompensated care. And so I think that we need to, again, transparency, accountability, and patient definition, I think, will bring up great actors in this program and give every hospital that's using this program an opportunity to provide excellent care to the patients they serve.
Great. I couldn't agree with you more. All 3 of those are extremely important, especially patient definition. To me, that would clear up so much about who is eligible and who is not eligible. Mr. Chairman, at this time, I would like to ask that this document titled How Abusive the 340B Program is Hurting Patients by the Community Oncology Alliance be submitted into the hearing record.
Without objection, so ordered.
Thank you. Let me ask you, Dr. Daniel, in your hospital, what qualifies a patient for a 340B?
First of all, they have to be under our care. That means that there is a relationship between the physician and the patient. Secondly, it means that they have to have been seen by one of our providers, and it means somebody with that contractual or employment relationship. And third, it relates to the encounter that generated the prescription being part of being seen in one of our sites.
Being seen in one of your sites, whether it's inpatient or outpatient?
It could be either.
It could be either.
Yes.
But yet we base it on the inpatient.
Yes.
Yes. That's, Mr. Chairman, I yield back.
Chair thanks, gentlemen. Gentleman yields back. The chair recognizes the gentleman from Oklahoma. 5 minutes for questions, please.
Thank you, Mr. Chairman. Thank you, the panel, for having a very long day with us. We really appreciate it. This obviously is an important issue. I'm just going to keep talking until the clock resets because I'll just have as much time as I want then. We good? All right. Anyways, I really appreciate you guys being here. I've just got a couple questions, and I'm going to yield what time I have left to my colleague from Indiana. He's going to need extra time because obviously he's pretty invested in this thing too. So my question is going to be to the whole panel. This committee has found that HRSA lacks significant regulatory authority to oversee the 340B program requirements. My draft bill allows HRSA to prescribe regulations as necessary or appropriate to carry out the 340B program. Are there any 340B program requirements that each of you can think that HRSA should further clarify?
I'll start, and that is, again, we look for guidance. We want to follow HRSA's guidance. Right. Some of the discussion around patient definition, I would be concerned if we started parsing what that is. If that's a patient of our entity, those savings will accrue to let us do service as an entity. So if you start dividing it by insured or uninsured status or the type of care, we do a lot of care, for instance, by telemedicine. We'll see a dermatologist, we'll see one of our patients that way. So some of these programs that actually save money and improve access, we would not want to restrict.
So what type of clarification would you need on that?
Well, I would be careful about how we limit something around patient definition. We'd be happy to participate in some of those conversations.
We would love some recommendations. The idea is that we want to give clear guidance. The whole purpose of this is the fact that there isn't clear guidance. And as Buddy, or my colleague from Georgia, had alluded to, that there's unclarity that is happening right now when it's designed, even what Dr. Dangles has just said, it's designed for inpatient, but yet it's also being used for outpatient services too. So there needs to be clarification on that. Not saying that Dr. Dangles is bad, it just needs to be clarified. We want it to be used for the intended purpose.
Yeah, I was just going to also add that I do think definition of a patient is critical, in a way that allows qualifying entities to use it appropriately. But I think given the tremendous growth in the contract pharmacy-hospital relationship, the variability and identification of a patient, and especially laxity in that definition, causes many challenges in inappropriate overuse of the program that, could be brought in by...
So what would that narrow scope look like?
Registration, looking at the provider status, making sure they're either employed by or have a contractual relationship with the hospital entity, looking at the origin of the prescription, looking at payer status, not that you have to determine by payer status, but that way you can at least note it so it can be reported, and demonstration of a relationship. And so that's historically done by things like medical records.
Dr. Dangles, do you have anything?
Only the comment, and I agree that it's important to define the patient. One of the concerns that I would have on behalf of UC San Diego is that in a redefined patient definition, that it doesn't serve to eliminate the benefits that come to the covered entities through the process. So in that sense, to not reduce the number of patients that would be qualified necessarily as a way to reduce the benefit that goes to the covered entity.
I'll yield the remainder of my time to Dr. Bashan.
Thank you for yielding. I want to talk about this criticism that what are we all worried about? It doesn't cost the government any money. I mean, it didn't cost us anything. We just heard that from our colleagues. I would make this argument. If we had transparency and we knew all the money was being used for the intent of the program, you could make that, I think you could make that case. When you don't have transparency, I think it'd be hard to explain to my constituents why a hospital put up a new $100 million tower. And part of the reason why they're able to do that is because they're using the revenue generated from the 340B program to support that activity. Here's the problem. We don't know. And so, I'm hopeful that if we do some transparency, that every 340B entity in the United States is in full compliance using the money for what they say. But we have multiple reports, including GAO and an Oversight Committee report from Energy and Commerce that says that that's not true. So anyone who wants to make the argument that, what's the big deal? It doesn't cost taxpayers anything? Well, it's a matter of where the money's being spent. If it's being spent for the intent, I would agree because, the money is being redistributed. It's not being paid for the drug itself, but it's being paid to help support care of those patients. But if it's being used by a system to support other activities, I would argue it's costing the taxpayer billions of dollars. I yield back.
Gentlemen's time has expired. The buzzer is votes have been called on the floor. So I'm going to go to Mr. McKinley. All subcommittee members having had time for questions, I recognize Mr. McKinley for 5 minutes.
Thank you, Mr. Chairman. As not a member of this committee, but I'm the sponsor of the House Bill 4392. I appreciate the chance to chat here a little bit with you. I think it's been enlightening to listen to some of the debate, some of the points, and it's where I wanted to make my remarks, and that was about the intent of this 26 years ago. And that was the intent was to provide discounts of drugs to providers to, quote, reach more eligible patients and provide more comprehensive services. I think it's pretty basic. We have, just as for the record, we have 199 co-sponsors on our piece of legislation. That's more than any of the other pieces that have been debated here. We want to put a moratorium on that rule because there are consequences for that rule as it goes forward with it. Because unless this rule is modified quickly, it's going to cut $1.6 billion from healthcare providers across America. And that there are going to be consequences. Hospitals and health systems are going to cut back on their services. We all see at one of the hospitals in West Virginia, WVU Hospital. They use the facilities. I listen with interest all the way the program is being used. And I know at WVU, they use it to fund a bus that goes around to be able to do mobile mammograms throughout West Virginia. And the cancer rate in West Virginia is the highest in the country. And they're trying to reach that using the 340B program with it. But yet, WVU Hospital is going to lose $10 million through this if this program isn't modified. Now, I could go on with it, that the Kentucky Hospital in Louisville, with 9 hospitals, is going to lose over $5 million. A clinic or a hospital in Cleveland is going to lose almost $7 million annually. And a large system in Greater Atlanta is going to lose over $5 million. I'm sure that we go on with example after example. There are consequences when we start reducing the funds from these hospitals. So I guess the question, Mr. Chairman, comes back is, has the mission of this program 25 years ago to, quote, reach more patients and provide comprehensive services, has it been accomplished? Can our healthcare system afford a nearly 30% reduction in healthcare funding and still survive? I think the answer is shouting. Of course it can't. And we have not achieved the mission. So our access to healthcare from both sides of the aisle, we have to have more increased healthcare access if we're going to take care of the folks in this country. So, well, we can continue to debate this rule or 340B program, but all the while, people aren't getting health care because of the $1.6 billion in cuts. So we can continue to debate this, but what we're trying to say, and I agree completely with Congressman Bouchon, is trying to reach the transparency. But I also say that the transparency is not only just for the providers, but it's also for the drug manufacturers. So what I'm hoping by issuing this legislation the way we did was to try to force everyone to come to the table, not just to debate forever, come to a conclusion. So, Mr. Chairman, I'm calling on you to keep the focus on this, please, that hospitals across this country, in West Virginia, $10 million, just one hospital.
Perhaps the gentleman would like to let the witnesses respond to his observations.
So I'm hoping that we can keep this focus, and I know I talked to the chairman about this. I feel we will, but the sooner we can come to a conclusion and something that can pass the House and pass the Senate, I hope we can do that. So I yield back the balance of my...
We don't have to yield back. We have 3 witnesses here who are experts. They may have opinions about what you've just said. You've got 42 seconds left. Dr. Cerise, do you have an answer or an observation?
So the change in Medicare reimbursement definitely has an impact on us, and I would suggest that there were concerns about the growth of the program or the oversight of the program, that we address it that way, and not by a reduction in the Medicare reimbursement for eligible providers who are using those savings. We get $152 million in savings in the program. It's a significant impact for us to be able to take care. There are 1 million people in Dallas County who are either uninsured or on Medicaid, and those funds allow us to take care of that population.
Dr. Daniels?
The process of trying to restore the OPP reductions is very important to us at UC San Diego.
Thank you. Yield back the balance.
The gentleman's time has expired. The chair observes that the chair has not taken time to ask questions, but as luck would have it, any questions that I could have possibly asked have already been asked at least 3 times, and you've answered them at least 3 different ways. So that's been instructive. It really, I mean, forgive me for a minute, Dr. Daniels. We just talked to my 2 Texans. We have 2 very different practice types, both impacted by the 340B program in different ways, and I think it is becoming just quite apparent today during today's discussion that, Dr. Pat, we need to take your considerations. They're very serious, and we need to take them under advisement. Dr. Cerise, we know you're the gold standard, and anything that we do should not disrupt what you have built at the Dallas County Hospital District, because it does provide an unbelievable service. You're unique. I mean, most of the other places throughout North Texas do not have an in-house pharmacy, strict formularies. I mean, there are there are reasons why what you do cannot be extrapolated across the entire North Texas community. Still, you work well with you get your mission and you perform your mission, and that's to be well commended. Dr. Pat, I am concerned about the consolidation, concerned about the fact that we are perhaps driving that consolidation with some of our activities. So I want us to work with both of your practices in mind. Certainly appreciate the accountability, the transparency, and patient definition message that you brought. You can see that message delivered, as well, of course, as the GAO previously had their 7 recommendations, all of which are worthy of our consideration. I'm going to yield back my time to conclude the hearing at this point. I have what? Seeing that there are no other members wishing to ask questions, I again want to thank our witnesses for being here today. I'd like to submit the documents from the following for the record: America's Essential Hospitals, Ascension, Texas; American Society of Clinical Oncology; Catholic Health Association; the Association of American Medical Colleges; Vox 304B article; U.S. Oncology; and Children's Hospital Association. One last commercial before we conclude. I ran through a litany of positive things that this committee has delivered for healthcare in this country, and Dr. Cerise, you reminded me, or maybe it was Dr. Pat, you reminded me of the DSRIP funds and the 1115 waiver, also worked on through this committee, and the extension or the prevention of the dish cuts that were supposed to go into effect last October 1st. That extension was provided by this committee, so the body of work is considerable for the last 18 months, and all I would say to that is you're welcome. Pursuant to committee rules, I remind members they have 10 business days to submit additional questions for the record. I ask the witnesses submit their responses within 10 business days upon receipt of those questions, and without objection, the subcommittee is adjourned. You got 5 minutes to go over and vote.
Yeah.